Difficult to say. Anyway, 10th of April, we make a comeback. We had a little lapse in the last couple of months, unavoidable reasons. As we said, we love you, so we always like to be with you. Presently on a virtual platform, but as time passes and if Father COVID or Mother COVID, whosoever he or she is, gives us the opportunity, we'll meet in person. Before I proceed, we congratulate our president, Dr. Raju Saitya of AFG, who's taken over the reins from the 1st of April 2022, and he'll be with us for this entire year. So, Raju, over to you for a few words, please.
Good morning and thank you, Manohar, for the kind introduction. Today we are discussing on a very vital subject, heart disease if some women is born with and when she wants to become a mother. Problems can surface or can get exaggerated. Also, we have to remember that there is risk to the pregnancy, that is the baby in the womb, to also suffering from the cardiac problem. So we have to be prepared for such eventuality, and it is very critical care, more so during the antenatal period and more so in the first trimester, to identify such patients and take care of them so that their journey towards delivery and childbirth and thereafter is smooth. With these few words, I and symposia, that is Dr. Kartik Bhagat, Manohar Motani, Mohan Gadam, and Rajkumar Shah, and to our esteemed invited faculties to please tell us more in aspect of this heart disease in pregnancy and its management. We have students with us who are going to present cases. I wish them all the best. Then we have the faculty who is going to speak on the subject. Also, we have one very crucial complication to be discussed, and that is cord prolapse, which becomes an absolutely immediate emergency, and we have to know how to handle it. I hand over now back to Dr. Manohar Motwani to take the proceedings further.
Thank you, Dr. Raju. Thank you so very much. So, friends, we have three guests today: Dr. Shailesh Kore, Dr. Girish Sabnis, and Dr. Padmaja Samant, and of course, our very own Dr. Mohan Gadam, Rajkumar, Kartik, and myself. And as he has rightly said, we are talking about heart disease, 2 case presentations followed by 2 talks and then a discussion on cord prolapse. It will not be a case, but it will be a discussion across. So people who have joined late, Iran is a small attempt made by AFG about 8 to 10 years back to bring teaching to the fore. We all felt it is time for us to give back. So the brainchild of Dr. Saraugi, Dr. Gadam, Dr. Rajkumar, Kartik, myself, and now Raju, we have come forwards. We hope and sail through the journey even ahead. Let's hope this continues and our enthusiasm doesn't fade. So also yours also does not fail. Because if you are there, we are there. If you are not there, we are definitely not going to be there. Fine. So here we invite Dr. Kore. Kore, good morning. Thank you very much from all the way from home on a Sunday morning. And I know you love students. You love students so very much. You've been surrounded by them at your hospital. Dr. Kore is the unit chief and the professor at Nyhc Hospital. After spending years in Sion and having remodeled Sion to a great extent, he's to Nyhc and handling the entire department there. And he's been a teacher for a long, long time. Almost 28, 30 years. He's been teaching students, surrounded by students. He's been an examiner, and he is an examiner even now for MUHS and other universities. So it'll be a pleasure for him to share his questions so the students get aware of the fact. Can I just make an announcement, please? Please, my dear friends out there, please mute yourself. We don't need to have more voices because otherwise the speaker's voice is going to crack and it disturbs the person talking. So a humble request with folded hands, my dear, folded hands, please mute yourself. Now let's come back to what we are here for. I'll hand it over to Mohan Gadam to give us an idea about the first student. And Shailesh, before I go ahead, Shailesh has been teaching for a long time and his questions are most welcome because you get an idea of how the exams are conducted. Apart from having more than 20, 30 awards and prizes, he's got about more than 80 publications. He's a teacher to the core. Loves the students. Welcome, Dr. Shailesh, once more. And hand it over to Mohan, please. Mohan, are you there? Okay, if Mohan perhaps is busy getting a set into the picture, should we invite the first student? I think Dr. Maunika Gottlieb. Monica, I hope I pronounced your name correctly. Welcome to the RAN. And just relax, breathe lightly. We've got good people across. They will not torture you. So, Monica, you can start your presentation, please. Karthik, want to add any few words?
Karthik sir, you can mute the other people since you are the host. You can mute the other people from where the extra voices are coming.
Then I'll have to mute all. And then
Karthik, do that. Mute all.
No, not mute all, but the remaining mic which are seeing not crossed, now you can just tap that. It will get used. Yes. Tap individual ones. I think
you're muted
Rucha
yourself.
Chaudhary and someone you can just tap and see it will get locked.
Okay,
Yeah.
okay. Let me try.
Yeah, you're audible.
All right, let us get on with the program. Monica, please start off. Well, Mohan, please, Mohan.
Yeah.
Mohan.
No, there's some problem with my computer here. Karthik.
Okay. Oh, we can hear you.
You can go on the phone, Mohan. Use your phone.
Yeah, can you hear me now?
Yeah,
We can
very
hear
well, very well.
Okay, 1 minute. Yeah, around 54 participants. Hi, good morning, everybody. Let's begin with the program today. We are going to have discussion on two topics, heart disease in pregnancy. And the second one is the short topic for management and interaction on cases of cord prolapse. So at the outset, let me congratulate Dr. Raju Sahitya. Raju is here for being the president of AFG. So it's going to be a wonderful year now. And Raju will take the reins of AFG for the next 1 year. So welcome, Raju. And,
Thank you, Mohan. Thank you, friend.
Yeah, and Raju, should we begin or you would like to give a small...
Please begin.
He has spoken, Mohan. He has spoken.
Okay, spoken once. Yeah, fine. Now,
Monica.
yeah, so there are two participants who are going to present a case. And the first one is Dr. Monica. She is a third-year gynec resident from Lokmanya Tilak Municipal Medical College and Hospital, and she'll be presenting on pregnancy with rheumatic heart disease. Is Monica there?
Yes, sir.
Very much.
Yeah, Monica. Yeah, please go ahead, Monica.
Good morning, everyone. My patient, 24-year-old, primary gravida with 6 months of amenorrhea, known case of a rheumatic heart disease, referred from a peripheral hospital for ANC registration at a tertiary care center. Her last menstrual period being 30 March 2021 and expected date of delivery being 4th of January, according to the Negle's formula. Gestational age by date being 23.6 and by scan being 24 weeks by the dating scan. She presented with the chief complaints of breathlessness on doing ordinary work since last 10 to 12 days, swelling over both the legs since last 8 days, palpitations since last 8 to 10 days, and easy fatigability since last 7 days. Patient gives history of feeling breathlessness and palpitations on exertion since last 2 months, but however, she was able to perform her daily activities without much difficulty. Since last 10 days, these complaints have exactly...
Monica,
Yes.
I'm just interrupting you.
Yes,
You said something about exertional dyspnea, right?
yes, sir.
So what is this? Can you just explain?
So dyspnea on exertion is a physiologically seen in pregnancy as well. But however, if this dyspnea becomes progressive, it is when it becomes pathological and has to be investigated further. Plus, she's also a case of rheumatic heart disease. So that is what is concerning.
Beta, we have not come to rheumatic till now. We're just discussing what is exertional dyspnea.
You said that she is a known case of rheumatic heart disease. Then what has happened in last 7 or 8 days, which suddenly she has started becoming breathless?
So it could be a case. So it could have worsened her previous condition as well. So that is why. Plus, that is why
Why in 7 days she will the condition will worsen? Do you think? Heart disease patient. She is a known case of rheumatic heart disease
since last 5 years, sir.
And Monica, she is 24 weeks pregnant.
Yes, sir.
And she is suddenly worsened. Now, a case of rheumatic heart disease, known case of rheumatic heart disease, when is she likely to worsen during gestation?
Likely at the age of 20. At 28 to 30 weeks of gestation.
28 to 30 weeks.
Yes.
Why?
So the amniotic fluid is maximum at that time. Plus also
Amniotic fluid.
Blood volume.
The blood volume is maximum at that period of gestation. So the maximum symptoms are seen at that age of gestation.
Now, can you just explain physiological changes in cardiovascular system during pregnancy?
So the
When
blood.
is the stroke volume and the cardiac output maximum as the pregnancy advances?
So the cardiac output starts increasing from fifth weeks of gestation. The cardiac output increases maximum at about 28 to 32 weeks, and the RBC volume is just increased to only 20%. There is apart from that, there is
Yes, you're right. Go ahead.
Yes, sir. And maximum seen at about 28 to 30 weeks, after which it plateaus, and she will develop maximum symptoms at that particular period of gestation, sir.
Yeah, so 24 weeks is good enough time for the patient to really worsen. 24 to 28 weeks of gestation, because that is where she is most decompensated during pregnancy, right? Yeah.
Yes, sir.
Hello. Yeah, go ahead, Monica.
Since last 10 days, these complaints have aggravated to an extent that the patient is not able to perform her routine.
Monica, are you sharing your screen? I don't see your slides.
I see it, Karthik.
I can see, we can see.
Because I don't know what is going to be recorded then. I don't see it here. Anyway.
Karthik, it is seen. It is seen and it is being recorded.
All right, fine.
Since last 10 days, these complaints have aggravated to that extent that the patient is not performing her routine activities associated with easy fatigability as well. She is also complaining of swelling over both the legs, which is increasing on walking, however, reducing on rest. No history of chest pain, giddiness, or syncope. No history of productive cough, hemoptysis, dysphagia, hoarseness of voice, paroxysmal nocturnal dyspnea, orthopnea. No history of cough, cold, fever, or any other bladder bowel complaints. No obstetric complaints of pain in abdomen, decreased fetal movements, leaking PV, bleeding per vaginal. No history of headache, blurring of vision, or epigastric pain. She's diagnosed with rheumatic heart disease in 2016, with severe mitral stenosis and moderate PAH with normal left ventricular systolic function. She got a balloon mitral valve to be done for the same, after which she is on tablet Pented, 400 mg BD, metoprolol 25 mg OD, and tablet Lasix 40 mg half. No other significant medical or surgical illness, or no history of blood transfusion and drug allergy. Patient, her LMP is 30th March of 2021, and expected date of delivery is 4th January 2022 by Negri's formula. Patient is sure of her dates. Her previous menstrual cycles is regular, so not significant. She is primary gravida, ANC registered at a private clinic at 12 weeks, received 1 dose of injection TT, and taking calcium and hematinib supplements regularly. Routine ANC profile are within normal limits. Anomaly scan done at 18 weeks is within normal limits. Total weight gain in pregnancy is 6 kg with pre-pregnancy weight of 48 kg. In present pregnancy, first trimester was uneventful. Second trimester is when the patient has developed symptoms of palpitation, breathlessness, and easy fatigability. She consumes a mixed diet with a total intake of 2,500 kilocalories per day. Sleep, bladder habits are normal. No history of any other addiction. Family history is not significant. General condition being fair.
Monica, if she was not a known case of heart disease, what was your differential diagnosis with only the history?
So there can be multiple causes for dyspnea. Any respiratory, she is complaining of palpitations and breathlessness and easy fatigability. Can be anemia is one of the most common cause for an Indian mother to develop these symptoms. Apart from that, I should be ruling out any respiratory and cardiovascular causes as well.
Okay. Did you she gave the history of known case of rheumatic heart disease?
Sir, based any I asked her.
So what history you asked, or did you see her papers?
Sir, no, sir. She was referred with a reference slip, which is which had details of her heart disease, sir.
Okay, go ahead.
Patient is conscious and oriented, average build, adequately nourished, with a weight of 54 kg at present, height of 155 centimeters, BMI 23 centimeters, no palar, icterus, clubbing, cyanosis, thyroid swelling, bilateral breasts are normal.
Which one are important in general examination as far as the heart disease is concerned?
So general conditions, apart from that, any cyanosis should be looked for. So both CVS and respiratory system should be examined. CVS look for the heart sounds.
So
in
the clubbing is seen where? What are the causes?
So clubbing is seen in respiratory conditions as well as in rheumatic.
Respiratory like means as far as your case is concerned.
So cyanotic congestive heart disease, so CC, congestive cardiac disease, heart disease is only so.
Cyanotic or congestive heart failure?
So congestive heart disease.
In a rheumatic heart disease, which condition will ultimately are more likely to cause a clubbing?
In rheumatic heart disease. So.
Yeah, means at what stage?
So congestive cardiac, in cases of failure, so basically.
Normally, the clubbing is seen when the patient has developed an infective endocarditis. Okay, and obviously, as you said, the cyanotic heart disease and sometimes in the pulmonary hypertension or primary pulmonary hypertension. And apart from that, the respiratory disorders are certain can lead to a clubbing. Okay, go ahead.
Bilateral pedal edema of grade 1 up to ankle. Her pulse rate is 98 regular, normal volume, equally felt in all 4 limbs. Her blood pressure being 100/70 in right arm sitting position, SpO2 being 90%.
What pulse normally you see in mitral stenosis? You said that she is a known case of mitral stenosis.
Yes, sir. In mitral stenosis, you will see a low volume pulse, sir. And yes, sir. Volume will be low, so that's
why.
So the cardiac output will be limited to because of the stenotic nature of the mitral
wall is in between where?
Between left atrium and left ventricle. So the cardiac.
So why the cardiac output will be less?
So cardiac
not
output,
aortic wall, no?
Yes, sir. But from left atrium to the left ventricle, the the amount of blood flowing is comparatively restricted. So therefore, there will be a low volume pulse, which is seen in mitral stenosis.
Okay, good.
Inspection, chest seems bilaterally symmetrical.
Just a minute, Monica. Anything else on per abdomen examination or anything on general examination you'd like to see in a patient whom you know is a heart disease patient? This is a question more for the medicine subject, but actually you have already made a mention. You have not made a mention of this. Neck. Will you see the neck veins?
Yes, sir. You look for JVP.
Yep. Go ahead.
Have you calculate JVP?
Sir, in the recumbent, you look for the external jugular vein. You see the maximum height of the in the.
How the patient is positioned?
Sir, in the at 45 degree from the sleeping positions, from the supine position, sir. Yes, sir. And the maximum height of the pulsations is measured, and from the sternum you place a ruler and scale, and then you measure the JVP.
And how you measure CVP then? From JVP? So normally you add 5 in the JVP because the atrium is almost 5 centimeters below the upper border of the sternum. So you add that, so that will be your CVP approximately.
Yes, sir.
And what are the other causes of edema during pregnancy?
Sir, at 24 weeks, I would not suspect any physiological edema present, sir. Preeclampsia can be presenting with edema, sir. And
Better refuse to accept 24 weeks no edema. There are so many patients at 18 weeks to come with pregnancy edema. So many of them come even earlier. So edema at any gestation can be physiological, can be pathological.
Yes.
Monica,
Yes, sir.
is there any condition where you call the patient has gestational edema, but she actually has no edema?
Okay. Gestational edema, but no edema.
Yeah. Clinically, there is no pitting on any of the extremities, but she is labeled as gestational edema. So in short, what I am asking you is, what is the definition of gestational edema? What is the definition of gestational edema? More than one plus edema in spite of 24 hours of bed rest. Is that called gestational edema?
So gestational edema will be up to ankle resolving on resting, so relieved on resting.
Yes. And any other definition of gestational edema? If the weight gain is more than 5 pounds per week in absence of edema, also is called gestational edema. Is that right?
Yes, sir.
Shailesh, will you correct me?
Yeah. Yes.
Okay. Monica.
Yes, sir.
Yeah. Now we are on edema, right?
Yes, sir.
Okay. Now tell us the grades of edema and where do you look for edema? Grade 1 edema, where do you look for grade 1 edema?
Grade 1 edema will be up to ankle. Grade 2 is up to
No,
knee,
where you look for it, sir asked.
Okay.
Ankle means where exactly? You said it is pitting, no? I think.
Yes, sir. Pitting.
Yeah.
Type of edema.
So how you check for the pitting?
So 5 over the shin of the tibia, sir. For 5 seconds, you are supposed
Tibia.
to.
You said grade 1, no? Up to ankle. So where is the tibia comes?
Sir, over the bony prominence, like medial malleolus, or.
Right. Okay. Anywhere else?
So for,
Apart from inferior extremities, anywhere else do you look for edema, especially when it is grade 1? You heard of pre-sacral edema?
I'm sorry.
Sacrum.
Okay.
Okay, over the sacral you can see behind. Right, these are two places where you look for pitting edema, especially when it is grade 1. Grade 2, grade 3 is pretty obvious. So you don't have to really, go behind and see. Okay, go ahead.
And you said that edema subsides after rest. Then is it because of heart disease or it is a physiological type?
Physiological, sir. More of physiological.
Your patient.
Yes, sir. Physiological.
Okay, go ahead.
On cardiovascular examination, chest seems bilaterally symmetrical, no dilated veins or scars seen. Apex beat is felt in the
Which scars you will see on the case of heart disease?
So I would look for a previous any replacement valve scars, parasternal scars present for a heart disease patient.
Any other scar can be there, which is not very common nowadays. There are sometimes the closed mitral commissurotomy is done, CMC, okay, where you see a scar in the intercostal 5th or 6th place, just lateral to the mid clavicular line. Okay, so those two scars you must see. Okay.
On auscultation, there is loud S1 and normal S2 in the mitral area.
Monica, on inspection, what are you likely to see in case of rheumatic heart disease with mitral stenosis?
You said she has a pulmonary hypertension, no?
So she was known, yes, a pulmonary arterial hypertension previously, for which she was BMV.
So anything pulmonary hypertension, what it causes as far as the heart size and heart ventricles
left atrial dilatation it would cause.
Okay, so what will that cause externally, clinically?
On inspection.
Manifest as what?
That's what sir is asking.
On inspection.
Inspection, palpation. Okay, inspection and palpation I can grant you. Okay, yes, right, you're right. Parasternal
heave should be looked for.
So what is parasternal heave? It is right parasternal or left parasternal?
Sir, right parasternal. Right parasternal heave, sir. Right, wherever there is increase in the pulmonary arterial pressure, there is right ventricular hypertrophy which is seen, sir.
Okay, fine. Okay, fine. We'll grant you that because we don't have to know more than this of cardiology. Okay, go ahead. Yes. Yes.
Sir, loud S1 and normal S2 in the mitral area with a mid-diastolic murmur heard with a pre-systolic accentuation in the mitral area. Chest is clear, sir. Air entry is
Anything
equivalent.
else you see on the auscultation, which is very important as far as the... She is already operated, but if she was not operated, then?
Sir, look for...
You also look for an opening snap, okay, on
Yes.
auscultation.
Yeah,
What
split second and an opening snap.
Yeah.
Loud first heart sound, split second and an opening snap, and a mid-diastolic murmur with pre-systolic accentuation, right? These
Yes.
are the classical features of mitral stenosis on auscultation.
Suppose you have two patients, one patient with opening snap and one without opening snap. Which is which one where you are going to be happy? Which patient? With or without opening snap?
So, without...
So normally opening snaps means that the walls are pliable. Okay, so that you can do a balloon mitral valvotomy. If the opening snap is absent, that means the walls are already calcified and they are not pliable. Okay, so that is generally happens in the advanced case. So generally in those cases, maybe it is not possible to do a closed the balloon mitral valvotomy. She may require, if the other findings are also collaborating, then she may require an open mitral replacement.
Epidurotomy, yeah. Yeah, Monica. Monica, what is split second due to?
Mainly because of...
The split second, the second heart sound is because of what?
So because of the closure of the mitral valves and the tricuspid valves.
So why is there split? There's a delay in closure, no, in one of the valves. That's why there's a split. Okay, have you heard of third heart sound on auscultation?
So yes, third heart sound.
No, you read obstetrics but not read cardiology, especially mitral stenosis. Third heart sound is due to what? And also tell me the disappearance of third heart sound. What does it signify?
Sir, third heart sound is because of the atrial contraction, sir.
The last rapid filling. The last rapid filling.
Rapid filling.
So the last rapid filling gives rise to third heart sound, and disappearance of third heart sound means what? Does it signify anything, any pathological condition? This particular patient is likely to go into atrial fibrillation. Yeah, that's why
Yes,
the third heart sound disappears. Okay. Okay, something about mid-diastolic murmur. What kind of...
One Girish, Dr. Girish Sabnis has joined.
Oh, he's there. He's there. But I'm just judging my cardiology knowledge.
No. So we have an expert at hand now, and he can chip in. Girish, you can chip in.
Yeah, Girish.
I will, sir, in some time. Please continue. Yeah.
No, Girish, please. Sorry.
No, sir. I'm just getting a hang of the case. I will ask in some time later.
Okay. Monica, tell me. I mean, whatever little I know about cardiology, I will just ask her.
Oh, that's a significant
and you
amount.
may please correct me later. Yeah, Monica, tell me. I am saying that this murmur is, the patient doesn't have heart disease at all, and this diastolic murmur is functional. Would you counter me?
So any type of diastolic murmur in pregnancy is pathological.
In pregnancy or without pregnancy?
So without pregnancy also.
Okay, tell me which are the functional diastolic murmurs.
So ejection systolic functional
Diastolic, sir, is
yes. Have you heard of functional diastolic murmurs? And you name them. Because unless proved otherwise, diastolic murmur is pathological.
Yes.
But there are exceptions. So which are those murmurs which may be functional? You just name them and then probably Girish will elaborate on it. Have you heard of Austin-Flint murmur?
Yes, sir. Austin-Flint murmur.
Have you heard of Graham-Still murmur?
Yes, sir.
Have you heard of Carey-Coombs murmur?
Yes, sir.
These are three functional diastolic murmurs. Okay, we'll know them as Dr. Girish will give his talk. Yeah, so you must know what are the functional diastolic murmurs. And often you can encounter functional diastolic murmurs in absence of, but unless proved otherwise, any diastolic murmur in pregnancy which is seen, you must make best efforts to rule out heart disease, right? Okay, and what does the pre-systolic accentuation mean?
Sir, right before the closure of the second, due to the mainly because of the atrial contraction, sir, there is a just before after the end of the diastolic phase, sir, there is a crescendo decrescendo size type of murmur.
Few more questions. What is the grade of this murmur and where it is more directed when you auscultate?
Sir, grading, sir, it is in the mitral area. And
what is mitral area?
Sir, at the apex beat is the mitral area, sir. Mid clavicular line, sir. Fifth, yes, sir. Fifth intercostal.
Right. Just it's directed towards the left axilla. It is directed towards the left axilla, right?
Okay.
Yeah, I'm saying that this is grade 6 murmur. I asked you what is the grade of this murmur, and I'm saying this is grade 6 murmur. Am I right or wrong? Can I be right or wrong?
No, sir. It is not a
grade 6.
Why I am wrong?
So it is not grade 6, but
no, but I am
why
saying
sir is wrong, he is asking. What is grade 6 in the other way? Other words, what is a grade 6 murmur?
Sir,
Dr. Sabnis is laughing at us.
No, sir, not at all. It's
okay, I think we are too much on cardiology. Last question, Monica. Anything else? What are the peripheral signs of AI? You will see in the heart disease patient.
Peripheral signs of
general examination. AI means aortic
insufficiency.
Sir,
at least 2-3, I think. Okay,
so
go
you
ahead.
Said atrial fibrillation.
Aortic insufficiency, aortic incompetence.
So there'll be low blood pressure in this patient. There'll be
there are around 10 peripheral signs which are commonly given, with the names. Okay, just read about it and go ahead. I think we got.
Shailesh.
Yeah.
Shailesh, I think there are signs of AS.
No, sir, it's aortic regurgitation only. All
right.
Hyperdynamic.
It is not aortic stenosis. It is AI only.
Okay.
Yeah.
Okay.
Wide pulse pressure and all that. Yeah.
Okay, Monica, go ahead.
Go ahead, please.
Yes.
Before we go ahead, can Girish summarize the physical signs that we are supposed to look for in a case of heart disease?
Sir, I joined in a bit late. I missed the. Can the candidate summarize the case for me?
Only the cardiac findings. You can. The general examination findings. Yeah.
So on the general examination, patient is general condition fair, so no with well conscious and oriented, average build, so with a BMI of 23, no pallor icterus clubbing cyanosis, thyroid swelling, normal, no bilateral breasts are normal. So bilateral pedal edema is seen of up to grade 2 with a pulse rate of 98 regular, normal volume felt in all 4 limbs, and blood pressure being 100/70, SpO2 being 98% on room.
Madam, in general examination, 2 points that I would always like you to mention in the anthropometry. It's good to say the arm span of these patients, because whether you are missing a Marfanoid patient,
Marfan syndrome.
upper limb upper segment lower segment ratio is may or may not be there. And another thing, you should mention whether there's a goiter or not, because thyroid and heart are inexpensive.
That she mentioned, I think, thyroid swelling.
Yes, sir, no thyroid swelling.
Okay, I didn't see it here. Oh, it's there. Sorry. Yeah. So goiter is an important thing to mention always.
And Dr. Girish, is it for OBGYN students, is it important for radial or radiofemoral delay?
Radiofemoral delay, because coarctation is something which can be missed. Even in a patient presenting as a pregnancy-induced hypertension may still have coarctation or a middle aortic syndrome due to Takayasu aortoarteritis. So if not radial delay, at least a detailed examination of the femoral and pulse and the dorsalis pedis is essential, because otherwise these will be missed and they will adversely affect the outcome. And then if the obstetrician misses it, the patient will never get referred. They will just be managed as an ordinary PIH, and that will cause issues later.
Okay,
So radial delay is welcome, but peripheral pulses must always be there.
Yeah. Okay, go ahead. Your obstetric examination.
So per abdos done in supine position after emptying the bladder and correction of dextral rotation, linea nigrans flag abdomen seen. Umbilicus is flat. Uterus is 20 to 24 weeks in size, corresponding to the gestational
At
age.
24 weeks, why umbilicus should be flat?
Yeah, umbilicus. Yes, sir. Yes, sir. It should not be flat.
May not be. It may not.
Yes.
Be.
May not be.
Yeah.
Yes. Symphysis fundal height being 22 centimeter, abdominal girth being 84 centimeter, longitudinal height, cephalic presentation vertex, FHS is heard.
At 24 weeks, can you check all these things? Cephalic presentation?
Sir, no, sir. No, sir. No, sir. Can't see.
Vertex floating?
No, sir. Can't see.
Normally in second trimester, what do you see?
Sir,
on examination?
On examination, we look for a external ballotment of the fetuses. Look.
So up to 22 weeks, you just see for external ballotment. You may not be able to hear also FHS, fetal heart sounds.
Yes, sir.
Right? Okay, good.
Monica, just a minute. To get more brownie points, would you mention about liver palpable or right hypochondral tenderness in these patients of heart disease? Palpation of the liver, spleen, is it important?
Yes, sir. It would suggest, yes, a palpable liver or spleen would.
Or a tenderness out there will make the liver congestion because of CCS.
Yes, sir. So would suggest of right heart failures.
Go ahead, please.
Sir, on investigating her further, her her ANC, her CBC is 12.1, sir, with the counts of 9,400 and 2 lakh platelet, 2,10,000 platelets, blood group being O positive, triple H being negative, thyroid being 1.54, fasting and the postprandial blood sugar in the range of 88 and 102. Urine routine microscopy is normal, sir. LFTs are within normal limits.
Monica, you will not get all these investigations in the exam. So these things you can discuss only when somebody asks you how you are going to manage. Okay. So when you are presenting in the exam, obviously all the reports are not going to be with you.
Yes, sir.
So you don't have to present like that. So only from clinical examination and history, what is your diagnosis now?
So primary gravida.
Suppose you didn't know that she's you didn't have her referral sheet. Only
Yes,
from the history and examination. What is your diagnosis?
Madam, can you summarize this case for me in 2 lines so that?
Primary gravida with a bidate lifespan of 24 weeks, 23.6 and 24 weeks with a known case of rheumatic heart disease with balloon mitral valvotomy done. Previous history of balloon mitral valvotomy done, sir, with query mitral restenosis, sir, not in failure, with no infective endocarditis. I'll be admitting her for safe confinement, sir.
And did the patient mention the names of these procedures to you? Balloon mitral valvotomy.
Discharge card.
On the record, sir.
Okay. Do you have access to these in the exam?
No.
Because it would be better to say likely valvular heart disease of rheumatic etiology, because that is the commonest in our country, with a femoral percutaneous procedure done, likely a balloon mitral valvotomy. Because then it appears too much to, there's nothing left for us to discuss once you mention all these things. So it's better that you lead the examiner to these diagnoses rather than directly mention them upfront.
And most of the time you will not get all these papers, in the exam. So you have to present as a de novo a new case where only from history examination you will have to give some diagnosis.
And Monica, you must give Nyhc classification.
Yes, sir. No, since grade 3, sir, on Nyhc classifications.
What does that mean? Can you just elaborate Nyhc classification and what is the significance in modern day obstetric management?
Sir,
Does that really hold true, especially for cardiologists?
Sir, grading, sir, grade 2 is when there is dyspnea or there are symptoms, dyspnea or ordinary activities, sir. But however, the patient is comfortable at rest. Grade 3 is when there is less than ordinary activity, patient develops discomfort and dyspnea and palpitations, sir. And grade 4 is when even at rest, the patient is presenting with dyspnea and palpitations and symptoms.
Okay, does this classification hold true in today's practice? Do we go by some other classification which is set by cardiologists? What is the right way to really classify the disease, to find out what is the severity of the disease? Obviously, Dr. Girish is going to talk on it probably, but just give me one salient feature. Would you go by this or would you go by the area of mitral valve?
Yes, sir. Area of mitral valve also would add to it, sir. Mitral valve normally is 4 to 6 centimeters square. Mitral stenosis can be whenever there is mild, moderate, and severe. Mild is less than 1.
Yes,
1 to
so
1.5
there are grades
is
of
moderate.
mitral stenosis on the basis of mitral valve area. Now, what is the biggest fallacy of the Nyhc classification?
Right.
It is based on subjective symptoms. It is subjective classification, and there can be a lot of fallacies in subjective classification.
Yeah.
What the patient
may be class 2 for one patient, maybe class 3 for another. So yeah.
Yes, so that's why the cardiologists will throw this out. Probably they will just go by 2D echo finding and the clinical finding. That is how they will refer to this. So Nyhc is going actually out of this thing. Now, so
we won't really throw it out. We'll highly appreciate if the doctor who receives the patient is sensitive to these findings, especially a mid-diastolic murmur, especially a right parasternal heave to detect pH, especially jugular venous pulse engorgement. All these signs, if they are picked up at the periphery, because otherwise many of these patients get diverted into the EMS as febrile illness with ARDS or whatnot, all kinds of diagnosis, and then very late when the patient goes on a ventilator, somebody comes, sees an echo, and then so it will definitely not be right to send a message that echo should be jumped in fast, because clinical is the first thing. You are lucky to have a patient with a discrete history of valvular heart disease and a procedure done, but most of them will not come like that.
Yes,
there will be multiparas who will realize they have a heart disease very late in their pregnancy.
So in nutshell, Monica, you must put them into Nyhc classification, come to a reasonable conclusion, and then refer the patient to a cardiologist to find out whether what you are saying is right or some other method of management and diagnosis need be done. So that is what
cardiologist will be most grateful when the obstetrician suspects and picks up heart disease early in the course.
Yes, very right. Okay, Monica, go ahead. How are you going to manage? Now, she is into grade 3 Nyhc classification, rheumatic heart disease. Well, what have we done? And re-stenosis has occurred. And she is primary and she's first time coming to pregnancy. She's around 24 weeks of gestation. And she is into grade 3 now. How are you going to manage this particular patient?
What investigations you will ask for?
Sir, after admission, sir, basic ANC profile should be complete, and after that ECG, 2D echo, cardiac opinion should be taken for this patient. In ECG, look for any signs of in ECG, basically you would look for any signs of atrial fibrillation or anything. And 2D echo, basically to look for the for any re-stenosis or mitral valve area in the pregnancy, sir.
So what are the signs of atrial fibrillation?
Signs of atrial fibrillation, there'll be no
it's okay. Any ECG you should systematically approach, starting with the P wave, the PR interval, the QRS complex, and a rhythm. So here you will first notice that a rhythm doesn't appear regular. Then you should see whether it is irregularly irregular. Then look at the baseline. You will not find any definite P waves. You will find a uneven baseline. Sometimes it may look like flutter in some of the leads, but it will always be a fibrillation. And as you rightly said, picking up atrial fibrillation is the most important thing, because it will completely, not only will it tell you that the disease is likely to be severe, because or there is a high chance that there is mixed mitral disease and not just MS. There might be accompanying moderate to severe MR, which is also very likely after a BMV. And third thing, the patient will need anticoagulation in the form of heparin and might need a transesophageal echo before we take the patient for a BMV to rule out a left atrial appendage clot, because that can embolize and cause a stroke during the procedure. So fibrillation is the single most important thing one should be aware of early in the ECG.
Monica, do you know what is Wilkins score on echocardiography?
Sorry, which score?
Wilkins score means what are the things you normally look for on the 2D echo? Means you will the report when you see the 2D echo report.
Wilkins score.
So normally when the patient is sent for 2D echo, what are the things normally you want?
So we look for any area of the mitral valve. So look for the ejection fraction in this patient, and any pulmonary hypertension, and
suppose she is not operated patient, and or you are the thing suspecting a restenosis, then you have to see whether the walls are pliable or no, if there is any thrombus or if there is a calcification or if there is a subvalvular crowding. Then I think Dr. Girish will throw more light on that, but these are the various things we see, and then depending on that, you will know whether the patient is fit, means a right candidate for a BMV or no. Right, sir?
Yes, I think so. Yeah.
Yes, I mean, frankly, Wilkins score is not something we look for, because Wilkins again was a Westerner who had done a small group of patients and then decided a score which we tend to think as gospel. But here, especially in the public hospitals, we see thousands of such patients. So we don't really stick hard and fast to the Wilkins score. We go much beyond the Wilkins score to decide, because if they say the moderate Wilkins score 8 to 10 should not undergo a BMV, we would do it in as high as 12 or 14. So it just depends on one's experience and the surgical kind of backup available and one's judgment from previous cases. So it's okay to not really know the score itself, but just to know that it's one way of judging. And also the other things, as was already mentioned in the discussion, whether there's a pre-systolic accentuation, whether the S1 is still loud, whether there's an opening snap, all these things tell us that the valve is pliable and is more likely to be suitable for a balloon procedure.
Right. Monica?
Yes, sir.
Yeah, now Dr. Sabnis was referring to something of atrial fibrillation in relation to embolization.
Yes, sir.
So can you elaborate why? Why did he refer this to?
So in case of mitral stenosis, there will be decreased blood flow from the left atrium to the left ventricle. So there is increase in the chances of the atrial fibrillation, and hence if there is a decreased diastolic flow, there will be increase in the chances of the thromboembolism in these in such patients. Sir.
No, it is not embolism due to what, but embolism of what? He did say that. He did say something. See, he was talking about thrombus which is present in the left auricle, right? Atrium. Yeah, yes. And under conditions of fibrillation, this thrombus gets dislodged.
Yes.
And then that is how patient lands up with peripheral embolization. So now, when you suspect embolization, what are the peripheral signs, clinical signs of peripheral embolization?
So there will be
when you
sudden onset
case of known heart disease, suddenly say that I am blind, I can't see anything. So what are you suspecting? Or she said, I have got acute pain in abdomen. Okay, I think he will talk about it, but it's important for you to know that. Okay, go ahead. Yeah.
No, sir, this won't be specifically mentioned. Please continue. Yeah. Hematuria, all peripheral pulses being present, sudden, even a transient blurring of vision or slurring of speech, we always err on the side of doing a transesophageal echocardiography, because you are in a patient of mitral stenosis, you are never wrong in doing a transesophageal esophagus, because the suspicion of an even if the patient is in sinus rhythm, the suspicion of a left atrial appendage thrombus is extremely high. And the word you're looking for the cause of thrombosis is stasis of blood in the left atrium. And 95% of all clots form in the left atrial appendage.
Right. Okay, Monica, go ahead. Yeah, go ahead. How are you going to manage this patient?
Sir, after
So you
admission,
put her into NYHA grade 3. She's 24
Yes,
weeks
sir.
pregnant. How are you going to manage? The cardiologist has seen, they have given directions. The patient follows up with the cardiologist as well as you. And how are you going to manage? What are the specific treatments or drugs which have been put on by the cardiologist in such a patient?
Sir, after 2D echo, after ECG and 2D echo, sir, if their 2D echo is suggestive of any moderate to severe mitral stenosis, that is when they would be advised to either get a either be managed medically or do a BMV done. In case of a severe mitral stenosis, they would rather advise a BMV which would be done for this
What are the
patient.
indications of BMV? Suppose she is not previously operated. Which are the patients which are you want to intervene during pregnancy?
So with the
Ideally, what she should get operated before the pregnancy or during pregnancy?
Ideally they should get operated prior to pregnancy, so that there is no worsening of the heart disease during the pregnancy. But however, if they are diagnosed with severe mitral stenosis during the pregnancy and a BMV is advised, it is ideally done in 20 to 24 weeks, sir. In the second trimester.
Okay, fine. Okay, go ahead, Monica.
Sir,
So
after
they've advised to put the patient on digitalis. Is this patient going to be put on medical management on digitalis? Will she be put on Lasix or diuretics?
So she should be ideally put on Lasix with a beta blocker should be given, and as a first line therapy, sir.
How beta blockers help?
So they reduce the heart rate and help in the left ventricular in maintaining the heart rate of 60 to 70. So there is filling of the left ventricle and to maintain the heart rate basically, so to reduce the tachycardia and development of atrial fibrillation.
Essentially, all the hemodynamics of mitral stenosis occur in diastole. So in a tachycardia, what shortens more is the diastolic phase. That
Yes.
will cause further increase in
Worsening
left atrial pressure, further flooding of the pulmonary veins and pulmonary edema. So, of course, the conventional teaching for most forms of active heart failure is that you should avoid a beta blocker because it depresses the heart. But MS is the only condition where you can pump beta blockers into a patient to relieve her dyspnea, whether it is sinus rhythm or atrial fibrillation. And again, I would like to say, as you rightly said, Lasix and beta blockers are the cornerstone. So one has to be extremely sensitive to monitoring potassium levels, calcium levels up to 20 milligram per day. It's not necessary, but if 40 milligram or more of Lasix are needed, then it's good to give syrup Kesol along with that. Because hypokalemia again can have extremely unexpected and disastrous consequences such as sudden arrest. So being sensitive to potassium levels is another message which should really be spread very strongly. Okay.
The second line of treatment. Beta blockers and diuretics followed. Okay. What is the role of this thing? Positive inotropic agents like digitalis and all. Okay. I think Girish will elaborate on this.
Digitalis will be considered only if the digoxin, only if the patient is in atrial fibrillation with the poorly controlled ventricular rate. But otherwise, with use of good beta blockers like metoprolol, digoxin is rarely indicated. And again, with concomitant use of Lasix, and since we can't use drugs which stabilize potassium like aldosterone in pregnancy, it's extremely scary to use Lasix and digoxin together in this patient. So it is best avoided.
Okay, Monica, go ahead. She's come in labor now.
Sir, if she has come in labor, sir, the ideal position should be propped up position. She should be given any pain relief, sir, and in propped up position with oxygen. And
Why do you need pain relief for such a patient?
Sir, to prevent tachycardia and to prevent pulmonary edema, sir, basically.
So what kind of a pain relief that you would like to give her?
Sir, we can give some epidural anesthesia is, if available, should be given, sir, by using bupivacaine and fentanyl.
Okay.
Or even IV opioids like morphine can also be.
Is morphine available that easily? Is there a substitute? Can we use tramadol?
Yes, sir, we can use tramadol.
What benefit does morphine have, if at all, if it is available, over all these pain relieving agents? Does it have a special benefit, especially in case of rheumatic heart and mitral stenosis?
Sir, it reduces the anxiety of the patients.
Okay. Okay, go ahead. What else? How would you manage in first stage, second stage, and third stage?
Sir, restricting the number of per vaginal examination and IV fluids in the first stage, sir. And
how much of IV will you give her?
Sir, 1 ml per kg.
Per hour?
Yes, sir. And 75 ml per hour.
Okay.
Sir, and basically, then in the sir, in the second stage, you would want to cut short the second.
First stage is over.
Sir, and so first
early
monitor
rupture
the
of membranes. Do you recommend early rupture of membranes in heart disease? Do you recommend routine use of oxytocin?
Yes, sir. We use a concentrated oxytocin in these patients, sir, with monitoring of the SpO2 also and heart rate for these patients.
Concentrated meaning, what do you mean by concentrated? How much oxytocin and how much drip?
How many
And
milliliters
if
per
she is
minute?
already in labor, sir said, then why you want oxytocin?
Let's come back to heart disease patients have got short labors or long labors? What's your experience and what's the normal teaching?
Sir,
on an average.
Short labor, sir.
Why do they have short labor, heart disease patients? Is cooptation. What is cooptation? Is it? Yes, it is. It is what is cooptation. The babies
or they go post-dated?
Sorry, sir. So the preterm labor is common in heart disease, sir, than postterm labor.
Yes, again, that is cooptation. All these, the babies are small.
Yes, sir.
The early delivery is more likely, and the labor duration is very fast. The nature has made adjustments.
Do your patient will require, because you are doing for vaginal examination, maybe catheterization, will she require a prophylaxis against bacterial endocarditis?
Yes, sir. We give an infective endocarditis.
What type of risk for a bacterial endocarditis? Are there any categories?
Categories for?
For risk of bacterial endocarditis, prophylaxis.
So,
I think
sir, ideally in any heart disease patient in pregnancy, we give a infective endocarditis prophylaxis of 1 gram of ceftriaxone if sensitive to penicillin drugs, and if not sensitive, we go ahead with 2 grams of amoxicillin.
Dr. Girish, nowadays the low risk patients are not given. Is it right?
Not given. So in this, how old is this patient, madam?
25. 25.
So again, you can consider Epidural prophylaxis, not endocarditis prophylaxis, but rheumatic fever prophylaxis.
That she's taking, I think, Pentid she's taking. No, you said.
Yes, sir. Penicillin.
Okay. Then just for her mitral stenosis, endocarditis prophylaxis is not guideline directed, but in our setting, we do end up giving a shot of antibiotic to most such patients. But if she had a prosthetic valve, or if she were a cyanotic heart disease, whether operated or not, or whether she is a unoperated acyanotic heart disease like a VSD or ASD, then they have to be given endocarditis prophylaxis. But again, in our setup, we don't stick to the Western guidelines too strongly. We end up giving a shot to everyone, even before a BMB, or whether it is labor.
Yeah, right.
Another thing to be touched upon in labor is, if I can at this stage, is it's not that every valve will be suitable for BMB. There will be the rare patient who will have, as in this case, any prior procedure itself is a kind of high risk feature for doing a second BMB. Though here we do it the third time, even fourth time rarely. But the valve does become more fibrotic, more tough. It may not be very obvious on echo, but we realize that only when we inflate the balloon and the valve tears at a wrong place, the rupture of the anterior mitral leaflet, etc. So there will be situations where we will not do a BMV and will need a surgery, and the patient is class 3 or above. So obviously, I'm sure the standard teaching is that the mother comes first. So we do sometimes rarely have to coordinate with surgeons to do a mitral valve replacement in the OT with a concomitant cesarean section and delivery. So such situations rarely do arise where we can successfully save both mother and child. So this must be kept in mind. The BMV may not be always the answer, though thankfully it is the answer in maybe 8 out of 10 cases.
Dr. Sabnis, when we were residents, we saw a lot of CMC patients, CMC.
Yes, it's
Now,
a lost start.
It's a lost start.
It's a lost start. It's a lost start. Dr. Tendulkar, etc., they used to, the frequency at which emergency BMVs happen in those days, in your early residency days, emergency CMC was the norm.
We have done, I think, seen many patients with CMC along with cesarean section, as you said.
Yeah, even
same setup. Yeah.
Some surgeons were good enough to come to the obstetric OT and put in a finger from a thoracotomy and open. But unfortunately, it is a lost start. Because again, BMV has become so widely available.
Okay.
Hello. Yeah.
Yeah, Monica. Monica, go ahead.
Second stage.
Second stage basically would be cut short the second stage of labor. Ideally, forceps should be used over vacuum delivery.
Routinely, or why you want to cut short in all patients of heart disease? You apply forceps vacuum.
Sir, in a known case of rheumatic heart disease with such symptoms, you would want to cut short the second stage of labor, sir, by using forceps, sir.
So, see, the right answer is you don't allow them to go into prolonged labor. Okay. If she is delivering in a reasonable time, I don't think you have to apply forceps or vacuum in every patient, because that itself is a risk. There can be a possibility of tear, postpartum hemorrhage. So you don't really want to apply. And if at all you want to apply, which one is better, forceps or vacuum?
Forceps is better, sir.
Why?
Sir, because there will be no maternal bearing down in forceps.
Who said?
So the maximum work is done by an obstetrician compared to a vacuum.
Bearing down is there in forceps in mother also, obviously. You tell her to bear down.
But definitely for vacuum, it is less. Any other advantage of vacuum? Because in many books, it is given the vacuum is preferred.
So the position is in vacuum, you can do a left lateral position delivery as well in vacuum. So
and you can apply vacuum early, no? You on a derotated head little early, say 15-20 minutes, half an hour before also you may apply when the cervix is fully dilated and station is appropriate. Whereas for forces, you'll have to wait for the conditions to be satisfied, and that may take time.
Yep.
So either way, I think you must cut short the second stage of labor, either with forces or vacuum, whenever it is feasible with vacuum.
Monica, what is the amount of blood pushed in the circulation during in uterine contraction?
During 500 ml of blood is pushed into the circulation with each uterine contraction.
Yeah, Dr. Girish, I have a question for you. Is there a role of prophylactic Lasix in the second stage of labor in these patients?
Are you saying that the mitral valve is still uncorrected?
Yeah, she has got worsening of symptoms and she has sunk in that 24-28 weeks.
Restenosis.
Yes,
But normally
if
when we
we
have a patient of heart disease, do we give a prophylactic shot of Lasix at that given time?
no, so we advise it only if the patient becomes breathless.
Okay.
But post-delivery also you don't recommend routinely?
If the
Normally,
patient
as
is not breathless,
normally recommend to give post-delivery because they are more
Yeah,
likely.
lot of blood being pushed in.
yes, sir. Here the patient would ideally already have undergone a mitral valvotomy, or we commonly deliver such patients in the ICU where the cath lab is just next door, so that we can rush them if at all we are unable to do a procedure before the patient comes to us in advanced labor. But yeah, it's again keeping an eye on the potassium levels. Lasix would be fine, but pumping in a lot of Lasix.
No, just 40 milligrams. Just 40 milligrams.
Yes, sir. But again, yeah, potassium all the way.
Yeah, but one single shot. we find it better and suitable.
Fair enough.
Yeah, our heart rate becomes maintained. Otherwise, we go into supraventricular tachycardia.
Otherwise, we also might go in failure.
Anyway,
Yeah,
Monica, you're doing well.
In
Monica,
what circumstances, Manohar, in
Yeah.
what circumstances a normal vaginal delivery can be, thought to be going on? When would you like to convert it and take her up for cesarean? What would be the reasons for that?
in other words, C-section and heart disease.
Sir, whenever the ejection fraction is less than 30%, severe mitral stenosis, severe aortic stenosis, not medically manageable or surgically managed patient. And then apart from Marfan syndrome with a aortic diameter of more than 50 mm, bicuspid aortic valve of more than 45 mm, you take the patient for a cesarean section.
What are the precautions you will take care of, and what is that you will keep ready when you are doing a section on such a patient?
So, under
Type of anesthesia, what will be?
epidural, yes, sir. The preferred anesthesia will be an epidural anesthesia for this.
Suppose she's a
patients.
patient of tight AS, you still give epidural in her?
Sorry,
AS. Tight AS, aortic stenosis.
No, sir, you would not give a epidural.
So it depends
anesthesia.
upon the cardiac
The type
condition,
of
depends
cardiac
upon the valvular disease, no? Because a sudden fall in the output will kill her.
Output, which yes.
Would you like to keep an intensivist or a cardiologist around in
Just
the
Raju, I think
Yes.
they do it in ICU setup, tertiary center only. Who manages heart disease in a private nursing homes anyway now?
So,
You have to talk about also talk about the third stage and fourth stage, and something about the contraception when you are talking about management.
Sir, right in the third stage, right after the
Shailesh, I think we should keep some questions for the next candidate.
Yeah.
Okay.
Let us not trouble this girl more. Let us not trouble.
Yeah.
Oh,
this girl
she is
Now,
she
Monica,
visits to it.
Monica,
Yeah.
you
Yes,
have done wonderfully well. We have stood that test in front of a cardiologist, so that's something which is very good. Now we'll just end with last question. Suppose you're given a choice in exams to either select toxemia in pregnancy or heart disease in pregnancy. Which one will you select and why?
So if I'm given a case, sir, I will select heart disease. So now, since I know all the questions.
Why? Why do you want to select heart disease?
Sir, since
You're right.
now,
In my opinion, I would also do the same thing. But why? What is your reason? And I'll tell you my reason.
so now I know what to study, sir, and what to answer and what.
Most of the examiners are gynecologists.
Yes,
So they also don't know
Monica.
much about
Monica,
cardiology.
you read a bit of cardiology and take the cardiology case because there is no cardiologist in the exam. And you can fool around with the gynecologist with cardiology stuff. Okay. So
not with this present set of examiners, sir. Not with the present set of examiners. I don't think she can fool anybody on cardiac questions also.
No. That's always better, but because you talk something wrong and probably it might be taken as a gospel truth.
So just one question here between in these cases, especially cases of left outflow of left ventricular outflow obstruction like severe AS or coarctation, as Motwani sir mentioned, what is the qualitative difference between spinal anesthesia and epicardial, epidural? Because spinal is absolutely contraindicated. Patient just crash, but is epidural still okay if we want to avoid general anesthesia?
Theoretically, in those cases, the GA is preferred.
GA is preferred, yes.
No, but suppose you want to avoid, yes, it is still okay.
Yeah, among spinal and epidural,
epidural is preferred among the two. Yeah.
If possible, we will give in such cases a general anesthesia.
Okay.
So again, just one point, because it may not come in my presentation. In the present era of advanced obstetrics, the only reason where to take a patient straight for LSCS without even giving a trial of normal labor would be active heart failure. Patient presence in class 4 is not responding to diuretics, etc. Yeah. Second would be again a severe coarctation with symptoms. Then a case where the aorta is actively and rapidly dilating, as in a case of Marfan syndrome, where there's or Ehlers-Danlos, other connective tissue disorders where there's a very high risk of acute dissection or rupture. These are, and when the patient is on uncontrolled anticoagulation, she comes to you in advanced labor and has already been on high dose warfarin, where hemostasis is much more under control. So these would be the only reasons in modern cardiology and obstetrics where patients should undergo LSCS as the first choice. Even cases which were previously recommended like Eisenminger, idiopathic pulmonary arterial hypertension, they can still be given a watchful trial of labor in an expert center.
Excellent, excellent, Dr.
Okay.
Sapni.
Fine.
Excellent.
I think, Raju, should we go on to the next one?
We should. I think
Monica, you
Yeah,
did well.
Monica, you've done a wonderful job. Please give her a big hand.
yeah.
And we pray that
you
you get a
have-
cardiac case. We
Yeah,
pray that you
because-
get a cardiac case.
Yeah, and you are in front of a cardiologist. So remember, so even if you have made some mistakes, I think they are all pardonable. So it's really great going for you.
Let's
And
take
thank
the
you very
second
much.
Thank you, Monica.
And let us now.
Five examiners is not easy to face. Of course,
And someone like Manohar. Someone like Manohar. And Dr. Shailesh Kore.
Oh yeah, both of them perhaps. Okay, anyway, chalo, thank you, Monica. Thank you.
Thank you, Shailesh, Mohan, Sabnis,
Shailesh,
Manohar.
hang on, Shailesh, don't run away. It's a Sunday morning. We can have you around.
Yeah, and let me just invite. Let me invite the second student. She is Dr. Madhura from KEM Hospital, and she is going to talk on pregnancy with congenital heart disease. Yeah.
Good
Madhura.
morning, everyone. I hope I'm audible.
Very clearly.
Yeah.
Yes.
Good morning. My name is Dr.
Manoj,
Madhura.
Padmaja has also joined.
Oh, Padmaja also is joined. Yeah, very good.
Wow. More the
Welcome,
merrier.
welcome, Padmaja. Welcome.
He is an internal examiner for
Hmm.
KM student.
I'm a second-year resident in the Department of Obstetrics and Gynecology from St. G.S. Medical College and KEM Hospital. And I'll be talking about congenital heart disease in pregnancy today. My patient is a 30 years female, married since 2 years, primi gravida, 33 weeks of gestation, resident of Amravati in a non-consanguineous marriage. She's educated up to MEd, but is a housewife at present. She has chief complaints of dyspnea on doing her day-to-day activity with easy fatigability since 1 week. She has had no history of palpitation, chest pain, or syncope. Patient gives history of congenital heart disease, which was diagnosed at the age of 5 years, but she has no history of operative intervention. She has no history of orthopnea, paroxysmal nocturnal dyspnea, hemoptysis. She gives no history of pain in abdomen, bleeding or discharge per vaginum, or decreased fetal movement. History of present illness. Patient was apparently all right 1 week ago when she gradually developed shortness of breath on doing her daily activity. She had no such episodes of shortness of breath preceding this. History of present pregnancy. Patient is a primi gravida with spontaneous conception. She was booked at a private hospital but further referred to KEM hospital for management. Her dating scan was done in the first trimester. Malformation scan and fetal 2D echo were within normal limit. Patient is on hematinics and has taken 2 doses of tetanus toxide. Her booking HB was 13.2 and TSH level was 3.09. Her ANC profile is otherwise complete and within normal limit. History of past illness. Patient is a known case of congenital heart disease diagnosed at the age of 5 years when she developed repeated cough and fever. A 2D echo was done, which was suggestive of a double outlet right ventricle with a large ventricular septal defect. She was advised correction for the same, but failed to undergo any surgical correction. She has no history of decompensation in the past, and she has no other significant medical history like hypertension, gestational diabetes mellitus, a thyroid disorder, or asthma. Menstrual history. She has attained menarche at the age of 13 years, and she has a regular cycle of 30 to 32 days, wherein she bleeds for 4 to 5 days with a moderate flow. Her LMP being 20th of August 2021, and her estimated date of delivery is 27th of May 2022. She has no significant family history of any congenital heart disease or any significant medical history. She has a mixed diet and gets adequate sleep with an intake of approximately 2,300 calories. She has no bowel or bladder complaints, and she denies any addiction. On her general examination,
so from history, suppose you didn't know that she has a VSD. What are the
Yes, sir.
most common congenital heart disease where the patient can go up to, become pregnant at age of 25, 30 and then go up to term?
So the most common heart disease having a very good pregnancy outcome is atrial septal defect, sir, wherein she will be carried to term, sir.
And what about VSD?
So VSD being the second most common, sir.
Okay.
Sir, yes, sir.
Go ahead.
Patient was moderate built with adequate nourishment and is febrile. Her height is 5 feet 3 inches, that is 160 centimeter, and her weight is 57 kg. Her BMI is 22.98 kg per meter square. She has no pallor, cyanosis, clubbing, icterus, or edema. She has no neck swelling or visible pulsations on the neck. Pulse was 88 beats per minute, good volume with no radioradial or radiofemoral delay, and peripheral pulses were palpable. Blood pressure was measured in both arms, which was 110 by 70 millimeters of mercury in sitting position.
Madhura, one question.
Yes, sir.
You said that the mother and the father, they do not have any congenital heart.
No, sir.
So how did this baby get it?
I'm sorry, I didn't get you, sir.
Yeah. So this is acquired illness. It's not genetically or transmitted from mother or baby to the baby.
Yes, sir.
Yeah. Now, which are the congenital heart diseases which are transferred or which can be transmitted to the offspring, and whether they are more often from mother or more often from father?
Sir.
And what is the risk of transmission when one of the parents is affected?
Sir, when one of the parent is affected, 25%. In general, there is, sir, in any fetus to have a congenital heart disease, the chances are 1%, sir. And if one of the parent is affected, the chances are 25%.
So which parent is more likely to transmit it to
the sir, the mother is more likely to transmit.
How many times that the mother is more likely to transmit?
So I'm not aware, sir. I'm sorry.
Okay, at least 3 to 4 times. Most of the times it is coming from mother. So is the heart disease from the mother, a congenital heart from the mother, which is more important for as far as the transmission to the offspring is concerned. So the yes, genetic transmissions, the incidence you all should know because that's something which is very important. If a heart disease is present, a congenital heart is present in the father, I think Girish might elaborate on these aspects, but by the way, I just wanted to confirm this.
So if it was a Marfan syndrome which was being passed on, then so there would be a 50% chance that the baby would develop it irrespective of the sex of the parent.
Yes, very right. Very right. Yes, okay, go ahead.
On examination of the respiratory system,
which again brings you to, you should have mentioned the arm span.
Yes, sir.
Not even gone ahead and said no Marfan or diabetes, because if you know it's a heart disease patient, this adds a lot to impressing the examiner. Whether yes, it's a medicine case, a OBGY case, or a cardiac case.
Yes, sir. On examination, the respiratory system air entry was bilaterally equal with no adventitious sounds or no crepitations. On inspection, her chest was symmetrical, no visible pulsations were seen. Her jugular venous pressure was 4 centimeters of water, and her apex beat was in the 5th intercostal space, just 1 centimeter lateral to the mid-clavicular line. First and second heart sound were heard with a pansystolic murmur present on auscultation. On per abdominal examination, on inspection, the abdomen was uniformly distended with no sinuses or scars with a globular contour. The umbilicus was stretched. On palpation, uterine size and symphysiofundal height was approximately 32 centimeters and corresponding to the gestational age. On fundal grip, there was a soft, non-palatable mass felt. On lateral grip, a continuous curvilinear structure was felt, which was palpable on the maternal left side. So, on pollix grip, a firm ballotable structure was felt, which was suggestive of the fetal head. Fetal heart sounds on auscultation were around 140 to 142 beats per minute, and regular. So my diagnosis from the history is a 30 years female, primary gravida, 33 weeks of gestation with congenital heart disease, Nyhc grade 2, not in labor, not in failure, and under evaluation.
Can you skip 2 slides behind, please, for the CVS exam? Okay. That was it. The pansystolic murmurs.
Yeah, she just had a pansystolic murmur, sir.
That's all.
Okay.
Yes, sir.
And that I have said that this is
Are you
your
allowed to mention saturation, because after COVID, everybody has a pulse ox, so that is no more a fancy investigation. In a cardiac examination, the SpO2
Okay.
I think should be mentioned. In this case, especially, it would be important because even saturations in the early 90s are important, but will not give you obvious clinical cyanosis.
Her saturation was within normal limits, sir. I had checked but not mentioned it in the slide.
Why did you not mention it?
So because I wasn't sure if a
Very
pulse ox
important.
would be available to us in our exam, sir.
But which grade pansystolic murmur was that?
You can bring
Sir,
your own.
grade 3 pansystolic murmur.
Yeah, I am saying this is functional murmur. She has no heart disease.
So grade 3 pansystolic, sir, grade 3 murmur. Sir, any murmur which is above grade 3 is a pathological murmur. Sir.
But it is grade 3, no?
3 or grade 3 above, sir.
No, and above also has exceptions, not necessary.
Okay, sir.
Yeah, and what percentage of systolic murmurs are functional, and what percentage in pregnancy are they pathological?
Sir, I'm not aware about the percentage, but
70%, 60 to 70% of systolic murmurs in pregnancy are functional.
Yes, sir.
So what are the other features which will suggest that she has heart disease and she doesn't have a functional murmur on your examination findings?
What is hemic murmur?
Sir, hemic murmur is seen due to hyperdynamic circulation of pregnancy. And that is also a systolic murmur, sir.
What kind of systolic it is?
Sir, it is a
pansystolic, ejection systolic?
Sir, it's a pansystolic murmur and it is a soft, short murmur, sir.
So what is a pansystolic murmur, a crescendo murmur and a decrescendo murmur?
Sir, a pansystolic murmur is the one which continues throughout systole, that it begins after the first heart sound. A crescendo murmur is, sir, ideally a crescendo decrescendo murmur is used to describe a mid-diastolic murmur wherein it begins a little after the first heart sound, peaks between the two heart sounds and will go on to go into the diastole, sir, like into the second heart sound.
Okay, and up to grade 3 murmurs could be more often functional. And more than grade 3 are more
yes, more than grade 3 will be pathological,
right.
Sir.
Yeah, right. Okay, fine. Go ahead.
Can I interrupt at this point?
Yeah,
I am a bit disturbed to see the side of the CVS examination because she has committed and said that the patient was diagnosed as double outlet right ventricle.
Yes, sir.
So again, it is you're treading in extremely murky waters by mentioning that if you had just said a VSD, but since you have specifically said that none of the findings here fit, because I don't want to complicate things too much, but DORV is the most primitive and the most complicated congenital cardiac disease. It flummoxes most cardiologists as well. It can present in multiple combinations. It can present as DORV is just the basic subset. When the heart is formed in the embryo, when it's just a tube folding, at the most primitive stages of folding, when things go wrong, you get a DORV. So DORV can be associated with pulmonary stenosis. So it will then present as a cyanotic heart disease. That's why I wanted a specific saturation. It can just be a mixing physiology where your saturation can still be 90, 92. You may not have obvious clubbing and cyanosis clinically.
Yes, sir.
And as you said, it is just a DORV with VSD. You did not mention PS. And you also said that the VSD was large, correct?
Yes, sir. It was a large VSD.
So that was a huge commitment that you made, because we tend to think that in a very simplified examination that VSD equal to pan-systolic murmur.
Yes, sir.
But DORV is what we call complex VSD. There are some other types. When you get a pan-systolic murmur, murmur always happens when there's a pressure difference between two chambers of
Two
the
chambers,
heart.
yes, sir.
And that's what causes flow turbulence. That's what you pick up as a murmur, correct?
Yes, sir.
So if only when your VSD is small, what we call in our language is a restrictive VSD, when it's a small VSD, only then will the pressure difference be high enough throughout the systole to cause a pan-systolic murmur.
Okay.
Yeah, cardiology is all about pressure differences between two chambers. There's nothing much else in cardiology, which we, as glorified plumbers, we either want to decrease or increase depending on the situation. So only when your VSD is small will you get a pan-systolic murmur. When the VSD is very large, correct, the pressure difference between the LV and the RV will not be significant. You agree with that?
Yes, sir.
If the communication between two chambers, the pressures will almost equalize. So your turbulent flow cannot happen, because since the pressures are equal, blood will keep flowing in a laminar way. So you will never get a pan-systolic murmur. You may not get a murmur at all.
Okay.
Yeah. So it is, and then what you will be dealing with in a lady in her 30s who had a large VSD, very likely it will be a VSD with reversal, or what we call as Eisenminger syndrome.
So I'm sorry, I'm asking you this, but there could be a bidirectional.
So you must ask as many as possible, because that's why I wanted to focus on this slide, because this slide has pulled the rug from under my feet, or maybe under your feet also.
Sir, I have this question. With large VSD, she was not in, she did not show any signs of cyanosis. So she was clearly not in Eisenmingerization. But sir, she could have a chance of a bidirectional flow, sir, because of the large VSD.
Okay, so bidirectional flow is what happens in Eisenminger.
No, sir, but the
Unfortunately, in
Eisenminger.
our country,
Yes,
most
sir.
patients, especially from the periphery, do not get diagnosed early. So
Yes,
these VSDs, Eisenminger is very early. Maybe in early infancy, she may have had a bronchopneumonia or two. It was ignored, managed at home. But by the time she would be even 6 to 8 months, such a complex VSD will reverse. It will reverse, and then the baby will suddenly become more stable. Parents will be happy, and then they will totally forget about it. And then they will get married. They will still have very high right heart pressures, and they will come to us with a pregnancy.
Yes, sir.
Then to misjudge them as a normal patient would again be inviting trouble later in the pregnancy. So this, when you have, I wish you had not uttered the word DORV and large VSD. If you had just said VSD, you could have taken us all on a nice smooth ride after that. So I didn't want to complicate things so much, but this is just not consistent, you know.
So my findings, I might be wrong in my findings, sir. But
No, your findings may still be right, but then you should not have committed to that DORV with large VSD, because large VSD cannot present with a pan-systolic murmur.
Okay.
If at all you hear a systolic murmur, it is an ejection systolic murmur, which may be because of pulmonary stenosis.
Okay.
So DORV, VSD, PS, it's like tetralogy of
TOF, yes, sir.
They are called top physiologies. Ultimately, it is the same VSD with obstruction to the pulmonary blood flow.
Yes, sir.
So that can very well present. It can still have a saturation of 90-92. They may not be grossly cyanosed.
Yes, sir.
But this just does not fit either side.
So because the 2D echo mentioned large VSD.
Yeah, exactly. So again, what the same thing which I tell my residents, yeah, maybe in modern exams, there is a trend that candidates know about the patient. But the art in the exam is to show that you are extremely naive and unbiased, and you started seeing the patient from scratch.
Yes, sir.
If you give out all your cards, then there'll be trouble. I mean, this is a serious problem. I could not, keep mum on this point.
Yes, sir.
And
Yes,
most
so
of the
let
time,
us just delete DORV large VSD, and we will be happy all over again.
Okay.
Yeah?
and most of the time in exam, you won't get any findings.
2D echo reports.
You have to talk or present.
So that you are unbiased is the main thing, that you clinically and diligently saw the patient and arrived at a diagnosis. If your diagnosis is wrong, that can even be a positive for you, if you can still defend it. But if even our residents, sometimes they tell us from the echo such severe MS with mild MR and mild TR with moderate PH, these things are not possible to know on clinical, then we know that they have known everything and it spoils the fun. Then the examiner just goes on getting deeper and deeper and everybody sinks in the quicksand. So that's just what I would like to highlight. Keep unbiased and just show that you are getting things out of the patient rather than reading obvious notes before.
Yes, sir.
Yeah. Okay. So let's call it a VSD patient
Yes,
who
with a
was
ventricular
diagnosed
septal
with a VSD and overall had an uneventful childhood and early adulthood. Then
Yes,
we
sir.
are back to track right now. Yeah,
Yes,
carry
sir.
on.
So my diagnosis is a 30 years female, primary gravida with 33 weeks of gestation with a congenital heart disease, NYHA grade 2, not in labor, not in failure, under evaluation.
Sinus rhythm would be very nice to mention every time. In sinus rhythm, in a regular heart rate.
Okay, yes, sir.
Yeah.
So how we are going to now manage is that 33 weeks.
Yes, sir. Sir, first of all, I would advise admission for this patient as she has degraded from NYHA class 1 to class 2 of her pregnancy, sir. Sir, as her ANC profile is complete, I would like to repeat a CBC and a urine analysis to rule out any form of infection to prevent chances of preterm labor. Since her sugars are normal, I will also like to
Preterm
give
labor
her,
or anything else you are worried about in the heart disease?
sir, bacterial endocarditis as well, sir. Sir, I would also like to give her a steroid dose for coverage as her sugars are also normal, sir, and she is at 33 weeks of gestation before 34 weeks, sir. Sir, I would not like to
All
induce
heart
this
disease patient you will give, suppose they come at 32 weeks steroids, or
sir. I'm sorry,
if
sir.
she's you said she is not in labor and not in failure.
Not in labor, sir, not in failure. Sir. Sir, heart disease has a higher chance of preterm labor, so I would prefer to give her a steroid coverage.
So that's what I ask you, whether all heart disease you will give routinely steroid shot at 32 weeks or?
Sir, this is my
Manor, you are
opinion.
not audible.
Hello?
Yeah, sorry. Here you are talking about infective endocarditis being prevented, and then we're giving steroids. Steroids are indicated when the threatening of a preterm labor across. You give a steroid 2 days, she doesn't deliver in the next 3 days. What's the point? You just given her unnecessary medication.
Okay, sir.
There's nothing like prophylaxis. Steroid prophylaxis when you're 28 weeks, she may deliver at 32. I'll give now. It has got no role, zero, zilch.
Okay, sir. Sir, I would for her labor, sir, I would like her to go up to term with a spontaneous onset of labor. I would not like to induce labor in any form, sir. Sir, in the first stage of labor, I would like her to, first of all, be in the labor room in a propped up position with O2. Sir, with her hydration should be maintained mainly by oral fluids. IV fluids should be avoided. Sir, repeated per-vaginal examination should be avoided. Input-output charting should also be done. Sir, in a second stage of, sir, to decrease her pain, analgesia would be preferred in the form of epidural analgesia. This would help her in decreases the chance of going her into cardiac failure by controlling the heart rate and as well as her anxiety. So in the second stage of labor, I would like to cut it short unless and until she doesn't deliver within 20 to 30 minutes of going into full dilation in order to prevent excessive effort from her side. Sir, for cutting short the second stage of labor, I'd use a forceps for that, sir. Sir, in third stage of labor, active management of third stage of labor will be done, sir. Sir, in this, we use a concentrated pitocin pint with 250 ml of RL with 20 units pitocin. Or another method can be used as IM 10 units pitocin, sir. Sir, we will not be giving methergin as it is not advisable to give it because it causes uterine contraction, which releases a large amount of blood, which will cause increase in cardiac output and which will precipitate failure, sir. Sir, and most importantly, in the first stage
Apart
of labor,
from that, methogen also raises the blood pressure, doesn't it?
yes, sir.
Patients?
So it's
So the
contraindicated.
oxytocin which you are giving will not cause a contraction and will not throw the blood in the circulation.
Sir, it does throw blood into the circulation, but
you know something with this thing, Madhura.
yes,
Even
sir.
I was under the concept, this thing, feeling that pitocin is not so strong, methergin is stronger. But once you go on reaching postpartum hemorrhages, methergin comes way below pitocin in terms of its oxytocin potential. So this teaching right from our grad days, methotrexate, severe this thing, and the blood is thrown. I think oxytocin is a much more potent oxytocin than methotrexate even today. But book language more so for the possibility of a coronary vasospasm and hypertension, which can happen with methotrexate.
Yes, sir. Sir, we give IV Lasix 40 mg post delivery in our institute, and sir, we also it is very important to monitor the
You
patient.
said it is VSD, so in first stage you don't want to give a prophylaxis in bacterial endocarditis?
Yes, sir. I'm sorry, sir. Bacterial endocarditis prophylaxis, especially in this case, as it is uncorrected, we should give. We could give amoxicillin or ampicillin 2 gram before 30 minutes before the procedure. Sir, another form is to continue IV antibiotics minimum for 5 to 7 days in her postpartum period. Sir, in the 4th stage of labor, it is important to monitor this patient especially for the first hour in an ICU bed. So the chances of going into cardiac failure are higher immediate postpartum, and for the first 24 hours as well, sir. And so that's it. And so for contraception, I would like to offer her progesterone containing pills, as it is safer, but barrier method can also be used since she's also a primary gravida. And I would also suggest her to not keep spacing of children for more than 2 years, as age also worsens the cardiac disease. So.
What are the indications of thromboprophylaxis?
So thromboprophylaxis indications are in a case of
in general heart disease. What are the different indications? Suppose you know that she is a patient of heart disease.
Yes, sir. Sir, she is a known case of cyanotic heart disease, in a case of uncorrected cyanotic heart disease, in a case of if a patient has had a history of thromboembolic episode in the past, sir, a history of if she has a history of atrial fibrillation, or she has a thrombus, that will not be prophylaxis. That's it.
And in certain cases,
yeah.
severe cases of peripartum cardiomyopathy.
Yes, sir. PPCM, yes, sir.
In which country congenital heart diseases will you contraindicate pregnancy? The patient comes to you in the first trimester 8 weeks. Which CHDs you will say no, you need not. You please don't continue your pregnancy.
Sir, severe coarctation of aorta.
We were taught Eisenminger, but I think Dr. Sabnis says that since we can handle Eisenminger also.
That's if they come to us in labor, LSCS, no, but definitely we would discourage a pregnancy if they come that early.
These are changing trends. I say things have improved so much that they can be taken for pregnancy.
No, but Dr. Girish, if they come in first trimester,
I'm in a seminar,
MTP. That's what Dr. Motwani is asking.
So if they come in first trimester, we invariably advise them to undergo an MTP, because the MTP per se is a low risk. As if in second trimester, then it has to be a discussion.
Okay.
Because the headaches on both sides are tremendous once they cross that threshold. But overall, a small VSD, as has been presented here, other than endocarditis prophylaxis, does not need anything special at all. And a brief mention of dental hygiene in the general examination, of course, would get a lot of brownie points, because poor dental hygiene is the worst cause of causing endocarditis in this patient. Yeah.
How you diagnose peripartum cardiomyopathy? What are the diagnostic criteria?
So peripartum cardiomyopathy occurs within 1 month to term or 5 months after delivery. She should not have any known cardiologic disorder or any structural abnormality in the heart.
So there are some 7-8 criteria, 5-6 criteria, no?
Not aware, sir. Sorry.
Are there any echocardiography criteria?
Sir,
related to ejection fraction?
Sir, I'm aware of the ejection fraction being less than 40%. There are 2 more, but I cannot recollect it, sir.
Dr. Motwani, you want to ask anything? Dr. Gadam is still there or he's left?
One has left.
Okay.
Sir is on mute.
Manohar, you're mute.
She has come out of peripartum cardiomyopathy. 6 months later, she comes and asks you, doctor, can I have another baby in the next couple of years? What would you counsel her?
So the chances of recurrence of a peripartum cardiomyopathy in a patient who has had a history is almost 40 to 50%, sir. So first of all, I'd get a 2D echo done, followed which I would get a dobutamine stress test done, and depending upon a left ventricular function, I would advise her whether or not to have a further pregnancy, sir.
Girish, would you want to add something to it?
I'll cover that in the talk, sir.
All
What
right.
are the various maternal mortalities in different heart disease? Maternal mortality rates?
Sir, I'm not aware of the rates.
Are you aware of the modified WHO risk classification?
Yeah, that's
Yes,
what
sir.
I'm asking you.
Class
Yes,
risk
sir.
1,
So
class
there are
risk
4
2.
classifications WHO has given us, sir. So the first class includes a small or corrected small pulmonary stenosis or corrected VSDs or ASDs, sir. So the second class includes Marfan syndrome without involvement of the aortic root. So it includes uncorrected congenital heart diseases. Sir, class 3 will include
Mechanical valves.
yes, sir,
mechanical valves.
mechanical valves. So class 2 also includes bioprosthetic valves, sir.
Yeah,
And class
bioprosthetic,
3 will
mechanical
include
valves.
mechanical valves, and class 4 includes Marfan syndrome with aortic dilatation of more than 50 millimeters. Sir, the Eisenminger syndrome, sir, the chances of severe aortic stenosis is again comes in class 4, sir. And sir, class 4 is with high risk of mortality, and medical termination is advised in class 4 of WHO risk.
Good. So all set? Should we move ahead, Karthik?
I think so. I think so.
I think she's done justice. Thank you, sir.
I think somebody wanted to ask.
Is there something on the chat
Yes,
box?
ma'am.
No, I don't think so.
I think so, ma'am.
Padmaja.
Yes, ma'am.
Padmaja, you
There's a
want to chip
question.
in something? Dr. Padmaja, does she want to chip in something?
There's a question here.
I wanted
Hemoglobin
to
is
ask
13.
Madhura,
Padmaja.
Madhura, if the patient requires or she comes to you with a request for tubal ligation, what will you tell her?
Ma'am, in my case, I will not deny her a tubal ligation.
Their partners hardly ever contribute to family planning measures.
Sir, ma'am, ideally the safest in any form of congenital heart disease or heart disease is to do a vasectomy, but that is not very famous in our country, so ma'am. So we would rather go. The females want to do a tubectomy. We will advise a mini lap tubectomy, sir, ma'am, with mainly epidural or spinal anesthesia, and laparoscopic procedures are contraindicated, ma'am.
Suppose this patient had come in first with a mechanical wall replacement in first trimester. History of mechanical valve.
Yes, ma'am.
Then
Yes, sir.
how you are going to manage trimester wise and in labor?
Sir, with mechanical valve, the main disadvantage is we need to give continuous anticoagulation throughout the pregnancy, which is not present in bioprosthetic valves, sir. Sir, in them, we will give up to 12 weeks of gestation. We will put the patient on heparin, and we will continuously monitor the APT till
Suppose she comes at 13 weeks with when she is already on warfarin, then?
Here, sir, we will have to counsel the patient about warfarin, chances of warfarin developing, the fetus developing a warfarin toxicity. But usually, since
Toxicity?
the therapeutic dose,
not toxicity.
Sir, not toxicity, sir.
Embryopathy.
Malformations, anomalous baby
Embryopathy.
Embryopathy, yes, sir. So we will have to counsel the patient about the same, sir. Sir, in this, we can routinely do her NT-NB scan and further do her malformation scan and then take a decision whether or
what
not.
malformation it causes?
Sir, it causes nasal hypoplasia, hypertelorism, optic atrophy, microcephaly with yes, sir. Epiphyseal stippling is also seen.
Why warfarin causes problem and why heparin is safe?
Sir, warfarin crosses placenta, whereas heparin will not cross the placenta, sir.
Why?
I'm not aware, sir.
Very basic, baby. Molecular weight.
Basic thing. It
Sir,
has a
the molecular weight of heparin is more, and that
Okay, so you switch over to
sir, yes, sir. Up to
first
12
time
weeks,
now.
we keep her on heparin. Then after 12 weeks, we
What
start.
heparin? Which heparin?
Sir, in our wards, we give unfractionated heparin, sir.
How much?
Sir, to begin with, it's if we are giving an IV dose, we can start with 5,000 international unit and TDS, sir, and then we monitor her APTT, and then we start the warfarin as advised by the cardiologist, which is usually at
So 12 weeks. Suppose she comes with a just missed period. For 12 weeks, you will keep the patient in the ward.
I'm sorry, sir.
If she comes with just missed period and you want to now switch over to a heparin, so till 13 weeks, will you keep her in admitted or you can discharge her?
Sir, we keep them indoors, sir, for the conversion. In the second trimester, then we continue the warfarin. And sir, a near term, we stop warfarin around 36 weeks and we start heparin, sir. So the disadvantage of warfarin is that it is long acting and it is not easily reversed. So we have to convert her to heparin, which can be, which is his period of action is around 6 hours. So that can be controlled. The bleeding can be better controlled on heparin when in labor, sir.
Does
What is the
heparin have an
antidote?
antidote?
Sir,
Yeah.
protamine sulfate is available, sir, and it is given 1 mg per 100 units of heparin, sir.
And how we monitor when the patient is on anticoagulation?
So for heparin, we use APTT, that is activated partial thromboplastin time, and for warfarin, we use PT
So how
INR.
much you keep it?
So the ideal is 2.5 to 3.5, the INR.
No,
Therapeutic dose.
I think Dr. Girish, can you just
Elaborate.
So APTT is thrice of
Okay.
the
Okay,
above
he is
higher
going to
value.
cover it.
No, thrice is very high. It's 1.5 to 2 times.
1.5 to 2. Okay.
And again, that's for unfractionated, not for LMW.
LMW. Yes, sir.
Suppose the patient in warfarin at 36 weeks comes in premature labor. Are you worried about the baby? You have not been able to switch to heparin, and she comes in preterm labor at 36 weeks and she is on warfarin.
So there will be a higher chance of intraventricular hemorrhage in the baby if the patient is on warfarin. So we will be worried about that, sir.
So in these cases, you may have to take in for a section to avoid
Yes,
this
sir.
head trauma, right? And what is the dose of warfarin which they say below this it is less teratogenic and below
So
above
5
this?
mg.
And what is the risk of teratogenicity in case she's on 5 milligrams in the first trimester? Do all the babies get warfarin embryopathy? What is the incidence?
No, I'm not aware, sir. I'm sorry.
About 10 to 15%. Correct me if I'm wrong, Girish, because you people deal with it more commonly.
Yeah. So if I just want to ask everyone if the patient needs a cesarean section, whether it is for obstetric reasons and has an underlying high risk or uncorrectable cardiac lesion, then what is the consensus on doing a TL in the same setting?
It's
In
a double-edged
private
weapon.
hospital, private hospital setup, definitely not, because they anyway they don't deliver a heart disease patient.
Dr. Girish,
Padmaja will answer.
Dr. Girish.
Yes, ma'am.
The thing is, in the standard guidelines for tubal ligation, there is nothing like contraindicated. It is delayed caution, special precautions, etc. But the problem, what you and I have been encountering is because of the government-sponsored insurance schemes. Okay, so the government-sponsored insurance schemes do not agree that the patient has died, means God forbid something happens to the patient, it is 99 times out of 100, it will be because of LSCS rather than because of that tubal ligation. But it becomes a TL associated death. That is why they don't get insurance. That's the problem. Otherwise, the standard guidelines do not say LSCS is, TL is contraindicated because you're opening the abdomen, you're getting the anesthesia anyway. But this is a political thing rather than a medical thing.
I just wanted that to be said by you, but it's a very painful thing when somebody would undergone LSCS before comes back with a pregnancy.
Tubal ligation,
I just like to add here.
But Padmaja, yeah, Rajkumar, go ahead.
So,
Yeah.
hello.
Yeah, Rajkumar, please.
Yeah. So, this is a very touchy point. Padmaja rightly nailed the, they hit the nail on the head. Basically, there are many administrative problems involved. Besides that, in India, the infant mortality rate is very, very high. A baby dying in the first 1 year is very high. So if you're sure that everything is fine, the patient has completed a family, then I think it is worthwhile discussing with them beforehand, rather than plunge to the idea of doing a tubal ligation immediately on the table there itself. So it's important to discuss this aspect right in the beginning. It has to be conveyed that there's a possibility that the child may be detected to have some heart disease on the third, fourth day of the neonatal period. So therefore, these are certain aspects which have to be kept in mind. It is always a good thing to prevent the further pregnancy in such patients as such, but other social factors also have to be considered before you come to this discussion. I think Padmaja wants to say something.
Padmaja?
Sir, what you are saying applies to all cases.
Yes.
Yes. In all cases. The problem is we have to consider second anesthesia for tubal ligation. And after multiple cesarean sections, the adhesions which occur and the difficulty we have in mini laparotomy TL, and the problem of anesthetists with doing a GA and laparoscopic TL. So all these problems considered
have to be considered.
Yes, and we should not shirk our responsibility, but the whole thing is become, because we stand like criminals in front of those death review meetings, that has created the problem. And nobody is talking about the way confidential inquiry should be up to 1 year. Many women die after 6 weeks, but we say, oh, thank you, she has died after 6 weeks, means my responsibility.
Yes.
It is stupid to do this.
Exactly.
Happening, and hardly care about that contraception of these women. Optimal contraception is not there for any heart disease, I would say.
True.
Yes, sir. Ma'am.
Padmaja, can I just add to whatever you have said regarding the touchy issue of a TL death?
Yes, sir.
Now it is settled in the court that if the TL date is directly related to tubal ligation and not related to concomitant surgery, then it should not be considered. So only if the date is related directly to tubal ligation, then the court proceedings will go on. If it is related to cesarean section or PPH or any other obstetrical condition, then the court proceedings will not be labeled as TL death. So this issue has been settled in the court in one of the judgments. So I just wanted to bring it to your notice.
I hope we get a copy of the judgment, yes?
Sir, that is agreed, fully agreed, but it is not the courts that haul us over the coals, It is the death review meetings that haul us over the courts. Patients hardly go to the court. Patients know the risks. Families know the risks. They don't take us to the courts. These death review meetings are the biggest deterrent to our...
Totally agree, ma'am.
Yeah.
Even as cardiologists, we are much more aggressive when a patient presents to us on day 43. So it's like rush to the cath lab on day 43, but conserve till that 42 days, which is in a way we are harming the patient because of the stress of the MATMOD meeting.
But another thing I want to bring it to your notice again, that death review meetings, in my opinion, they are all humbug. They pin down the doctors. They do not pin down deficiency of services. They do not want to take any action against the institutes which have caused delays in transport, unavailability of ambulance, non-availability of residents, non-availability of respirators, and all those things. But every damn thing is pinned down to the doctors. And I had a tough time fighting with these people when I was head of the department at Cooper Hospital. So it's a very touchy subject. And the weakest focus is on the doctors. So if anything goes wrong, it's a doctor who is held responsible, which is a tragedy. And confidential inquiry into death review, you need to actually find out, and most often 70-80% of the times it's deficiency of service which causes a problem.
Exactly.
So, friends, I think
that this is not the platform to discuss our views, and let us not scare them. Let us not scare the students about what they are going to face later.
No, this is not the point, but we're just bringing out these issues which are important.
Signing on a very positive note on this auspicious day of Ram Navami, let's hope wisdom dawns on these administrators and the patients ultimately benefit. So friends, thank you so much, Madhura. You've done so very well,
Thank you,
well.
sir.
I think
Thank
you
you, ma'am.
asked the question so very well. Thank you so much. You did well.
Thank you.
And I think we will move with the second part of the work today. And we have two talks today. One is the diagnosis and medical management of heart disease, and the other one is the obstetrical management. For the first talk, we have Dr. Girish Sabnis, who's been with us for the case presentation. So very nice if we get Dr. Girish to join us on a Sunday morning. Dr. Girish is the associate professor in the Department of Cardiology, one of the most premier institutes in the country, the KM Hospital, Mumbai. And he's been a topper. He's got a tremendous amount of accolades for his undergraduate and postgraduate days. He stood second in the DM cardiology exam, multiple publications, loves to teach, and he's been really a pleasure and a treat to have you for the last 1.5 hours. We look forward to your presentation on diagnosis and medical management of heart disease. Over to you, Dr. Girish.
Yeah, so is my screen and voice clear?
Voice is clear, screen is
loud and clear. Screen is also seen.
Perfect.
I just want to minimize the names. Just a second, please. Anyway, okay. So I'm very grateful to the organizers for this opportunity, and I'll try and cover this extremely vast topic of heart disease and pregnancy. I just need a second to minimize the I can't seem to get rid of the videos on the side. Anyway, can I continue?
Yeah, please continue. Please.
Heart disease in pregnancy, we will see more and more of such cases. They are a common cause of tussle between obstetrics and the medical branches. Again, as we have already discussed, the strict laws can often become an impediment. So the only defense against these is strong knowledge of the basics and knowledge of the guidelines. But after having worked in KM for 10 years, one can say that guidelines are only a support stick. They are not always your best defense, because every possible permutation combination of symptoms presents in our recovery room. So finally, a very joint discussion with the obstetrician and cardiologist in the best interest of the patient is the only way out. So as a background, pregnancy is complicated by maternal heart disease in up to 4% of cases. And the mortality would be variable depending on various publications. With in India, it shows 15% when the mother has heart disease. This incidence will be rising due to increasing age at the first pregnancy and increased survival of those with congenital heart disease as in the second case. Also, as more and more elderly ladies become pregnant, the incidence of diabetes, heart disease, obesity, other such lifestyle problems are more prevalent. Just a second, just minimize this. Get rid of this. Not everything. Is there any other way to get it out? Now, yeah. Okay, yeah. Where is it? Play. Okay, yeah. Sorry about that. So again, as lifestyle and chronic conditions become more common and more older patients get present, heart disease is also likely to improve. So thorough knowledge is important. Again, for statistics, hypertension is the most common cardiovascular disease in all pregnancies, whether it is chronic hypertension or pregnancy induced. Congenital heart diseases are more frequent in West, whereas good old RHD still continues to dominate in our part of the world. Now let's quickly touch up, though it was extensively discussed, about all the hemodynamics of pregnancy. The plasma volume will increase by up to 50% in the early third trimester. Cardiac output will increase by about 43%. Heart rate by 17%. The diastolic BP falls. Systolic BP will either remain the same or minimally increase. Stroke volume will increase by about 30%. The systemic vascular resistance as well as the pulmonary vascular resistance fall. So it is important to know that the cardiac output that rises during pregnancy in the early part of gestation is caused by an increase in the stroke volume, and in the later pregnancy it will be due to increase in heart rate, because cardiac output, as we all know, is stroke volume into heart rate. Again, in labor, the cardiac output will increase from 7 liters per minute to up to 9 to 10 liters per minute due to the 500 ml auto transfuse during every contraction. With epidural and LSCS, it can be brought slightly down. What happens after delivery? So the parameters will take up to 6 months to come down to the baseline pre-pregnancy values, especially the cardiac output. Again, one must be very alert in patients without what we call as known heart diseases, that the normal changes in pregnancy may look like cardiac symptoms and vice versa. So one has to be really careful. In antepartum counseling, again, how do we explain the family and the patient about the risk and decide the obstetric course of a pregnancy? So what we have is the modified WHO classification, and in the scoring systems, we have the CARPREG and CARPREG 2 scores which can be used. So as the second candidate had very lucidly described to us, class 1 of the WHO class mostly includes relatively milder lesions and isolated premature beats, which have a low risk, nearly as much as a normal pregnancy. Class 2 to 3 most commonly will be SVTs, which are benign, unoperated acyanotic heart diseases. Class 3, which is the more dangerous one, will have unrepaired cyanotic heart disease, which will be most commonly the tetralogy of Fallot in our country, and moderate LV impairment with EF between 30 to 45%. And of course, most commonly mechanical valve. So we have a common saying in cardiology that rheumatic mitral heart disease is one disease, but mitral valve replacement may sometimes become a worse disease for the patient. And of course, ventricular tachycardias. Then class 4, which is the most serious diseases, will include idiopathic pulmonary arterial hypertension, severe heart failure of EF less than 30%, or when the patient is in Nyhc class 3 or above, and severe mitral stenosis, amongst others. So these patients will have an extremely high risk, poor maternal and fetal outcomes, and pregnancy to be avoided or managed more aggressively in the later stage. So touching upon the risk scores, not that we commonly use these, but these are good to know for maybe insurance, medical, legal reasons, and to explain to the patient. So the initial CARPREG score just included the high risk predictors as on the left, and depending on the number of predictors, the risk could be stratified. Whereas the CARPREG 2 risk score gave up points to each of these factors, as seen on the right. And according to the number of scores, the score more than 4 carried the highest risk. So this score is good to know, but not compulsory. Again, how do we manage, using this score, how do we manage? So first we use the WHO classification to decide whether lesion itself is high risk. So if it fits into class 3 or class 4, then you call it a high risk lesion anyway. But in lesions which fit maybe 1 or 2 to 3, that's where we can use the CARPREG risk score to further detail the risk and accordingly stratify the patient. Now touching upon which drugs to use, which drugs to avoid. So we can broadly classify them into 4 broad classes. The absolutely safe drugs which we commonly use are adenosine, digoxin, beta blockers like metoprolol and bisoprolol, propranolol, the antihypertensive labetalol, metoprolol, nifedipine. In heart failure, again, the beta blockers, diuretics, and in anticoagulation, aspirin, UFH, and LMWH. Drugs with limited conflicting interest, again, will include certain of the antihypertensives like amlodipine, hydralazine, anticoagulants like clopidogrel, which may be considered safe when the benefits are more, and the anti-pulmonary hypertensive drugs like sildenafil. Drugs to absolutely contraindicate are the ones given in red, which are dangerous to both the mother and child, And the column in light blue shows drugs to be avoided in breastfeeding. Now, how do you evaluate and test a patient once the clinical impression is made? So the transesophageal transthoracic echo is the safest and most sensitive method. May be technically challenging, but is now very commonly available, especially in the metros. Exercise testing, which may either include a treadmill stress test or a bicycle ergometer test or a cardiopulmonary exercise test. It may be performed prior to a pregnancy so that we can do better antepartum counseling, antenatal counseling, sorry. It should be limited to a sub-maximal test if it is performed during an actual pregnancy. That is, we don't make the patient stressed till she is absolutely exhausted. We just do it till certain basic parameters are achieved. The use of dobutamine should be avoided. CT overall, unless the benefits to the mother in diagnosis are absolutely higher, is to be absolutely avoided since the fetal radiation exposure is tremendous. CMR may be used in specific conditions. Cardiac catheterization, again, in cases like idiopathic pulmonary arterial hypertension, or if the patient has developed an acute coronary syndrome, there with judicious use of coronary angiography and cardiac catheterization is indicated. Now we'll go to the specific illnesses, covering on the most common diseases first. So which are the acute illnesses which require emergency care? Those would be acute coronary syndrome, acute heart failure, pulmonary thromboembolism, and acute arrhythmias. And chronic conditions would be valvular heart disease, chronic heart failure, and adults with congenital heart disease. So just as a case snippet, we had a 40-year-old diabetic hypertensive lady who came in advanced pregnancy and had retrosternal burning since the last 2 hours. The ECG to our horror showed an acute anterior wall myocardial infarction. So overall, what should be the approach to ACS? With the rising diabetes, hypertension, more and more cases are seen. In COVID, again, we saw ACSs, which we presumed because of the COVID without adequate proof. So there can be a 3 to 4-fold increased risk in pregnancy compared to before pregnancy for the same lady. The risk factors would include advanced age, obesity, dyslipidemia, and additionally, pregnancy-induced hypertension, multiparity, postpartum infections, or hemorrhage. The etiology, again, as in the general population, coronary atherosclerosis would be the commonest. But one has to remember that in pregnancy, again, spontaneous coronary artery dissection, or SCAD as we call it, is also a very likely cause and is much more common than in the general population. Intracoronary thrombus, coronary spasm are the rarer causes, and one has to distinguish between pulmonary embolism, aortic dissection, and preeclampsia as a differential diagnosis. So just as a quick reference, how do you diagnose an ACS? You either see ST elevations or ST depressions in the ECG. You may see evolving changes. Common ECGs to not miss would be of an anterior wall MI with ST elevations in the anterior leads, or an inferior wall MI with ST elevations in the inferior leads 2-3 AVF. Now the management. So as is still happens, most people who present with MI will still undergo thrombolysis with agents like streptokinase. So it is controversial whether that should still be the approach in a pregnant lady, since spontaneous dissection is a commoner cause than atherosclerosis, where thrombolysis may not necessarily help relieve the obstruction. Thrombolytics do not cause the placenta, however, they can still cause maternal or placental bleed. So the preferred choice when a patient presents with an acute coronary syndrome in pregnancy is to take her to the cath lab. As here you can all see a large thrombus in the middle of the right coronary artery. So such a patient can be still prevented from thrombolysis and maintained on heparin for a few days if otherwise she is stabilized. So urgent angio is the preferred treatment. Pci Techniques, stenting in rare conditions may still be required. Dual antiplatelet therapy, if a patient receives a stent, only then we can consider clopidogrel to be safe in her, considering the risk-benefit ratio. Going on to other medications, the safe beta blockers and aspirin, nitrates, calcium channels if patient continues to have angina, clopidogrel if a stent was needed, and the ACE inhibitors, ARBs, are contraindicated till the patient delivers. I don't mind being stopped in the middle if I'm going too fast or giving too much information. Now we'll go to the delivery and postpartum for an acute coronary syndrome. So the current recommendation would be vaginal delivery with epidural anesthesia. Postpartum and lactation, again, ACE inhibitors and statins can be restarted because they are mortality benefit drugs in this class of patients. And given that pregnancy is a risk factor for developing recurrent coronary artery dissection, future pregnancy should overall be discouraged. Second, after ACS, we'll go to acute heart failure. So again, as a case snippet, a lady in advanced pregnancy with PIH and presented with class 4 dyspnea, orthopnea, giddiness, and peripheral cyanosis. Her echo showed dramatic LV dysfunction. So what should be the approach to left ventricular dysfunction and heart failure in pregnancy? So these are the common causes of heart failure. Cardiomyopathies, amongst which peripartum would be the most common. Idiopathic dilated cardiomyopathies, non-compaction, right ventricular dysplasia, ARVD, myocarditis. Again, in COVID times, myocarditis had raised its ugly head, very chemotherapy related. These are all the things when there is isolated myocardial dysfunction. Then associated ischemic heart disease, where there will be regional wall motion. The whole LV won't be dysfunctional, as we just saw in the echo. Pulmonary hypertension, valvular heart disease, congenital heart disease in the adult, whether the patient has been operated or even post-operatively, and chronic arrhythmias, all can cause left ventricular dysfunction and heart failure in pregnancy. So in this, again, the most specific one that needs to be touched and discussed is peripartum cardiomyopathy, which, as again Madam said, is towards a month before and few months after delivery. It's a non-ischemic cardiomyopathy. So angio may need to be done in all cases to document that, because it's more or less a diagnosis of exclusion with reduced LV function less than 45%. Diagnosis, again, a transthoracic echo would be the most common. Serum BNP levels may be done to rule it out rather than rule it in. And a cardiac MRI to rule out other associated causes like myocarditis or infiltrative disorders. Myocarditis, the specific pattern in peripartum would be this diffuse subendocardial LG of the LV, as can be seen in the faint lines in the rim of the endocardium in the MRI images. So what are the management options? Again, during pregnancy, standard heart failure management, keeping away from the contraindicated drugs. If it's really bad in advanced centers, mechanical cardiac support may be needed, and deliver as early as possible. Again, there should be a cardio-obstetric team with hemodynamic support and caution for fluid overload, especially after the delivery. After pregnancy, standard heart failure management, including the ACE inhibitors, can be included. A drug which can have specific benefits but has still not found its way into definite guidelines is bromocriptine. So bromocriptine at a dose of 2.5 milligrams once or twice a day for a few weeks can show benefits, but we reserve it for patients who have a really low LVEF or who present in class 3 or above refractory to the other drugs, because it suppresses lactation and can cause problems for the baby. And again, one thing to remember, that if you are giving bromocriptine, it predisposes to LV thrombosis and anticoagulation has to be given. It may be considered in other cases, but if you are using bromocriptine in peripartum, anticoagulation has to be given. Then again, more advanced centers would give you a wearable cardiovascular defibrillator if the LV function is really bad. As you know, there are 3 ways to defibrillate. It's the defibrillators that we have in our emergency ward. Then there are things called ICDs, which we implant like a pacemaker in the patient. So all these things cannot be done in an acute setting. So patient can still go home with what is called a wearable cardiovascular defibrillator. It's like a hunting jacket strapped to the patient, and it can deliver a shock. But again, it's still not commonly used. And discussion of contraception. So what are the outcomes? Overall, the worse the LV function and presentation, the less is the chance of recovery. So with higher LV function, up to 90% of patients may recover near normal LV function. And therefore, these patients need a continued surveillance. The fourth thing will go is venous thromboembolic disease. So again, it was discussed which patients are more predisposed. IVC congestion because of the gravid uterus, overall pregnancy being a prothrombotic state. The incidence of venous deep DVT can be up to 0.2% and pulmonary embolism 0.03% with a significant case fatality rate. So medications, again, we had discussed would be anticoagulation and advanced options like systemic thrombolysis in unstable patients. Diagnosis, again, for we have certain scores like the Wells score, etc. for pulmonary embolism, but these may not necessarily apply to pregnant patients. Therefore, we have to test more aggressively with tests like D-dimer, a low dose pulmonary CT pulmonary angiogram, considering the benefits to the mother. Echo can have limited role, but it can still show thrombi in the proximal pulmonary artery. And ECG can show the classical S1, Q3, T3 pattern. MRI venography, again, not commonly available to us. So these are the, I am quoting the 2018 European Society of Cardiology guidelines for most of these recommendations. So for venous, just to summarize the main ones, LMWH is recommended. It should be given based on weight and not in empirical doses. Thrombolytics only when the patient has hypotension or shock. We should stop LMWH and convert it to unfractionated heparin around a couple of days prior to expected delivery. Active management of the stirred stage to prevent hemorrhage, and an extended dose of LMWH may be considered. Again, an important one was the novel anticoagulations like dabigatran, rivaroxaban. They should be avoided in pregnancy, but can still be used after delivery. These may be the ECGs with some of the patients present to our recovery room. So this is a supraventricular tachycardia. This more broader QRS complex is a ventricular tachycardia. So again, going to arrhythmias in pregnancy. As we said, the first ECG, the PSVT is atrial fibrillation. All these are overall low risk, and hemodynamically unstable ventricular tachycardias in those with a known substrate like heart disease or cardiomyopathy, or channelopathies like Brugada syndrome or long QT syndrome. These will be the high risk patients. Management, again, as a rule of thumb, when the patient is hemodynamically unstable, give a direct shock. Do not worry, because it's generally very well tolerated by the fetus mother. The chance of inducing preterm labor is extremely minimal. So always take expert help, but overall one does not need to be a cardiologist to know that any hemodynamically unstable tachycardia should be shocked. And if it's a ventricular tachycardia or an atrial fibrillation, we should press the sync button on the defibrillator. That's just something good to know. And if it's a ventricular fibrillation, you should not press the sync button. You should directly give a large 200 joule shock. So just to summarize, the supraventricular tachycardias can be terminated by simple maneuvers like massaging the carotid artery. And very advanced, then one has to consider anticoagulation in chronic atrial arrhythmias like fibrillation and flutter. And catheter ablation can be like atrial EPRFA, what we call, can be reserved for very few cases refractory. Ventricular arrhythmias, if a patient presents, we should always look for what caused the ventricular arrhythmia, whether it was a channelopathy where like Brugada syndrome or the long QT syndrome, or whether the patient had a structural heart disease or peripartum cardiomyopathy. So again, in an acute setting of a VT, IV amiodarone may be used, 150 milligrams over 10 minutes. Procainamide, isoproterenol, not commonly available. And shock if the patient is hemodynamically unstable. Ask your cardiology colleague to rush to the labor room. After we shock, of course. Then we'll go to the next largest class, that is valvular heart disease. Overall rule of thumb is regurgitant lesions like MR and aortic regurgitation are far better tolerated than MS and AS. So going on to mitral valve, the murmurs were extensively discussed. So the length of the mid-diastolic murmur is more important than the intensity. and how whether the S1 is still loud, whether the OS separation from the A2, all these are clinical factors which help us decide what intervention to use. So the second trimester is the most common when symptoms worsen and mortality can occur if the NYHA class is 3 or above, or if the patient has associated severe PH or is elderly, the prognosis will be worse. These are common ECGs of MS with sinus tachycardia, left atrial enlargement, and a classic X-ray with pulmonary edema and a straightened left heart border. So again, in an elective setting, after 20 weeks of gestation, initially it used to be 24 to 28 weeks, but now with advanced NICU facilities, even after 20 weeks of gestation, we can plan a PTMC or a BMV. If the patient is in NYHA class 3 or above, or if the systolic pulmonary artery pressure is high, we do not wait for that period. We do it in maternal interest at any stage. And if patient continues to be symptomatic, there are no absolute contraindications like wall characteristics, and preferably in an expert center where minimum fluoroscopy time is used, as abdominal shield is placed on the patient's tummy, as you can see in the fluoroscopy image below. The fluoroscopy image shows the BMV or Inouye balloon being inflated, and the waist in between is the balloon in between is the mitral valve, which is being opened up. And of course, an obstetric team on standby in case there's a precipitate or preterm labor. Anemia correction again cannot be stressed high enough, because anemia always decompensates patients much faster than otherwise. So we have to know that these valve lesions will have maternal as well as fetal outcomes, both during pregnancy and after delivery. Next, going to aortic and aortic wall diseases. The hemodynamic and hormonal changes during pregnancy will increase the susceptibility to dissection, especially in patients with underlying connective tissue disorders like Marfan and Ehlers-Danlos, and even bicuspid aortopathies. The most common causes of valvular aortic stenosis would be a bicuspid aortic valve and rheumatic heart disease. Heart failure would be rare in moderate AS, and even in patients with severe asymptomatic AS, pregnancy would be well tolerated in an expert center. But if exercises testing may be recommended in such patients, but if the patient is having symptoms, the AS has to be relieved. Again, the severity can be judged from the classic crescendo-decrescendo murmur of aortic stenosis, where if the murmur is late peaking, as you can see in the diagram on the right, and if the aortic sound is happening much after the pulmonary, as in the S2 is wide split, then you can say that the AS is more severe. So this would be just for reference an ECG of aortic stenosis, which shows very tall QRS complexes in the lateral precordial leads showing left ventricular hypertrophy. In management, again, intervention should be recommended only if the patient is symptomatic or has compromised LV function, or when they develop symptoms during exercise testing. It may be considered in asymptomatic patients when exercise testing reveals a fall in blood pressure. Normally, BP should remain the same or increase during an exercise test. In expert centers, a balloon aortic valvuloplasty can be considered when the valve is suitable and when there's no significant regurgitation prior to the procedure. Again, this is how AS will affect outcomes. I'll skip this slide. Now, coming on after native valvular heart disease, we come to prosthetic valves. So as I had mentioned earlier, rheumatic heart disease is a bad disease, but sometimes metallic mitral valves and MVR can become a worse disease owing to the complexities of anticoagulation, the compliance with anticoagulation, and the disasters if the valve gets thrombosis, what we call a choke valve. So these are just some common images of valves. So we should know the common names like the bioprosthetic valves, which do not have a metal disc. So valves like Epic, Biocord, these are all bioprosthetic valves. And the column in the lower row shows the metallic or mechanical valves, which common names would be again St. Jude valve, Medtronic valve, the Star Edwards ball in cage valve. We should just be aware of the name so that at least we know what kind of a valve we are dealing with. So again, as was again discussed during the case discussions, these are the recommended protocols for switching in a patient with a known valve, mechanical valve, when she comes in pregnancy. How do we switch between oral and vitamin K antagonists and heparin? So this has already been broadly discussed. So this figure will be available for reference, but this is the best way. If the patient is on a low dose warfarin 5 milligram or less and is willing to be closely monitored, she can still continue it into the second trimester. But otherwise, a safer option would be LMWH. They can even take it at home if necessary. Next, we'll go to congenital heart disease. Just for interest, if we want to guess what all are the possibilities, so there are some surgical scars which you will see on the lady's body, which will tell you what it is more likely to be. So if you see a scar just under the clavicle, she is likely to have a pacemaker. If you see a lateral thoracic scar like 1 and 2, then a left thoracotomy can indicate that she had undergone a BT shunt for TOF in childhood, or a PDA ligation, or a coarctation repair. If there's a right thoracotomy scar, as in number 2, again it can be a right BT shunt, a mitral valve repair, or rarely even an ASD repair. But if it's a sternotomy scar, you can be sure that it was a major surgery which needed bypass. Yeah. So going on, as again already summarized, those with a successful closure of isolated acyanotic diseases are at a low risk for complications during pregnancy. Unoperated ASDs, women with most unoperated VSDs, PDAs, which are small or restrictive as we call them, these do not, as in the case Madam had presented, these do not need any additional cardiac precautions during the antepartum pericardium period. Eye prophylaxis should suffice. Significant aortic coarctation, which impedes delivery to the blood distal to the upper limbs, which increases the risk of growth retardation and premature labor. Women with unrepaired coarctation, they can be offered beta blockers, and stenting or repair should be reserved to after pregnancy. But again, this will need an expert handling of the second stage of labor, not necessarily LSCS as the absolute modality. In case of cyanotic congenital heart lesions, if the saturation is 85% or less, then both the maternal and fetal outcomes are dismal. Complications would be mortality, heart failure, arrhythmias, both supraventricular and ventricular, thromboembolism, and bleeding. Frequent echocardiographic and clinical surveillance is recommended. Activity limitation and careful vaginal delivery whenever possible. So we do get a lot of patients with uncorrected tetralogy of Fallot who our obstetric department has very successfully delivered. But again, there's the issue of what contraception to give them so that they don't come back to us. So to summarize the whole talk, this is a nice central illustration where you decide based on the WHO class of the lesion, the preconception care, who to receive what kind of counseling, baseline assessment, imaging, risk scoring, pregnancy risk assessment for both the mother and the fetus by an adult congenital heart disease specialist. There should be a pregnancy team comprising of the obstetrician, cardiologists, primary care, and nursing, referring to specialized centers whenever necessary. And the monitoring needed during the pregnancy. Mother with congenital heart disease is a strong reason for advanced fetal echocardiogram. Then regular monitoring of the maternal echos, symptom-driven testing whenever necessary, and serial testing of blood tests. We already have had a broad discussion on management of concepts of management of labor according to the heart disease, but I'm sure Madam will take it beautifully in the next talk. So these are the broad references and bibliography of my talk, and I'll end with that. Thank you. I'll be happy to take questions if I can, or we go to the next talk.
Dr. Sabnis, it was perhaps one of the most comprehensive lectures. You literally covered the entire topic. Beautifully done. I think it covers every area. It must be a treat for the postgraduate students. I hope they've taken screenshots. Anyway, thank you so much.
I think it was very important that he was on the case discussion also, that the points he
brought. Before I forget, I would like to thank our third year registrar, Dr. Ankita Kulkarni, who helped me with preparing the slides. And yeah, because they are the ones who again get into maximum quarrels and squabbles with the obstetricians before it gets escalated to HOU and HOD level. But yeah, I think more such joint talks will help create a more congenial and peaceful discussion between obstetricians and cardiologists.
So this is the beginning of the invitation.
Yes.
We will see you more often. And it was wonderful to have you on the panel. Now there are a couple of questions.
Yeah. Karthik, you are muted.
Sir, you are muted.
Okay, there is a question about aortic dissection at 27-28 weeks. How do you manage? Then there's another question about a heart transplant done 8 years ago. How would you manage pregnancy and delivery? So if you can answer these questions in brief. And there is one more question which said hemoglobin is 13. Is it high or normal for Indian women? Okay.
Regarding aortic dissection, overall rule is they are classified into 2 Stanford times. So any dissection which involves the ascending aorta is a surgical emergency. So the patient has to be taken on table by the surgeons. And there again can be an obstetric team where an LSCS may be done in the same setting while the patient is still on bypass. So frankly, I have not thankfully encountered such a situation, but that would be going with the accordance with the guidelines. What was the second condition, sir?
Heart transplant.
Heart transplant. Again, we are not a transplant center yet, and we have not yet seen such.
Delivery.
Correct. So post transplant, again, I'm not very sure how the most important thing here would be how the the immunosuppression should be managed, which would be considered safe and which will need to be stopped or modified. So that would be a very major consideration. Then the initial few year or two after transplants, pregnancy should be discouraged. And beyond that, it would depend on the left ventricular function, whether there has been any early onset of coronary rejection. But I will not lie. I'll be lying if I say I have great experience in this subset of patients. So that will need some reading.
These are specialized issues, so it will need specialized care. And how would you consider hemoglobin 13? High or normal for Indian women?
Yeah, again, for any intervention, the holy grail for us is 9.
All right, so we stick to the figure of 10. All right. It was wonderful to have you, Girish, and we'll see more of you.
Thanks. Sir.
Yeah, just the beginning of our association, Girish.
Manohar, let's proceed with.
Yeah. Thank you, Girish, once again. Beginning of our long association with you, and here we have the next talk of the day, that is by Dr. Padmaja Samant. She is a postgraduate teacher for ages, I know, for a very long time. A very warm person, too very good in academics. And it's a pleasure to have you, Padmaja, today. And she is a professor at the OBGYN department in KM Hospital, GS Medical College. She has other loves in her life also. She has done a postgraduate diploma in bioethics and healthcare management. She is a member of the MUHS task force for curriculum implementation. So she's really gone way ahead of OBGY. And she works with a lot of NGOs like Sehat, Sneha and Majlis. And another extracurricular love of her life is she is a founder member of Division of Medical Humanities in KM Hospital. So Padma, it's going to be a pleasure having you with us. So
may I add that Madam has been my MBBS teacher as well?
Oh yeah, she's been a postgraduate teacher, undergraduate teacher. She's a teacher for so many things. Anyway, Padma, over to you. It'll be a pleasure listening to you.
Thank you, sir. Is the screen seen?
Absolutely.
Okay. So what we are going to talk is obstetric management, and what we are not going to talk also I will discuss. But what we will see in next few minutes is the physiological confounders, which so many times we happen happen to miss, and nowadays, especially after, this is for residents, especially after COVID, people, when they stopped going close to the patient, they stopped auscultating patients. They started taking fetal heart with a handheld Doppler, but it is important to auscultate maternal heart. It's so important because we cannot always depend upon investigations for diagnosis of heart disease. By then, patient will have fallen through the gaps. So physiological confounders, knowing that risk stratification, which has been discussed in Dr. Girish's talk, as well as in the case presentation by Madhura and the earlier case presentation, and contraindicated pregnancies, then management of pregnancy, labor, puerperium, and preconceptional counseling. Very briefly, though we have touched upon MTPs, very briefly I will touch upon MTPs. So the masquerading signs and symptoms in these things are breathlessness, edema, palpitations, and a systolic murmur. If somebody really sincerely puts a stethoscope to the heart, are the signs and symptoms which may be available, present in normal patients as well as in the cardiac patients. So clues to familial cardiac conditions is very important. Knowing the distinction of murmurs is important. Then history, prior cardiac surgery, myocardial infarctions, stroke, aortic dissection, and of course sudden death is not history, but all these relevances, all these history factors are quite relevant. So what we'll be doing is we'll be talking in this sequence sort of valvular disease, congenital diseases, aortic diseases, and ischemic heart disease. This classification we have referred to 3 to 4 times in last few minutes. Forget the grade 1 where the corrected ASD, VSD are there, and pulmonary venous circulation, but we will focus on these. Grade 2 is mild mitral stenosis, and a host of our patients will be in this particular lesion will be there. Then moderate aortic stenosis. Grade 3 will be mechanical valves, moderate MS, and I'm sorry about that repetition. Then grade 4 will be severe mitral stenosis, severe symptomatic aortic stenosis, and anticoagulation will be there in the grade 3. So when patients in any of these categories come, we require to stratify them, and we require to have a multidisciplinary approach where not only the cardiologist but the anesthesiologist also and the neonatologist have to be involved, because anesthesiologist, because all our management is going to depend upon the epidural analgesia that they're going to give, the anesthesia that they're going to give, even if MTP is there, and even if we do medical termination by MIFI-MISO, we may require them to give us support for curettage, etc. And post-operative complications in these patients, we may not be really able to handle alone ourselves. It is important that anesthetist is also with us in this, along with the cardiologist. So there are certain predictors of neonatal and maternal events which we should be focusing on. These being the maternal events, the predictors being woman in NYHA class 3 or 4, then a woman with left heart obstruction, somebody with cardiac medication before pregnancy, whose saturation is low, then a person with mechanical valve, and a person with high pro-BNP because at 20 weeks, because she has a higher chance of having a episode of failure or a cardiac event during subsequent weeks of gestation. And our delivery management in these patients will also be different. Then predictors of neonatal outcomes will be if somebody is with multiple gestations, person on anticoagulants, because it has to be a very planned delivery. We cannot have a patient coming with anticoagulation on and in preterm labor, or in labor she has been lost to follow-up, and this happens umpteen number of times. Actually, many of our patients are out of towners, and they come, they don't have place to live in Bombay. They go back and they come Sometimes they may not come. In pandemic, they had great difficulty coming back. So these patients really pose a challenge because the baby will have intracranial bleed risk. Then abnormal placental Doppler, because here we are going to juggle with the maternal stabilization, maternal optimization, and the the fetal optimization. How would we be delivering these patients? The vaginal assisted delivery in significant MS in NYHA class 1 and 2 is recommended. Again, I am also referring to the guidelines which Dr. Sabnis quoted, the European Heart Association guidelines. These are patients without pulmonary hypertension. So assisted with forceps, their outcome is very optimum. Cesarean section is generally considered in patients who are in NYHA class 3 or 4, or those who have pulmonary hypertension and commissurotomy or BMV has not been done for them. Then cesarean section is recommended in moderate to severe aortic stenosis. Generally for regurgitant lesions, vaginal delivery is recommended. We will take into account what Dr. Kore also had said some time ago when he said that we do not allow them to go into prolonged second stage, and we may choose between the two modes of assisted delivery depending upon the station, rotation, etc., etc. Then in severe symptomatic aortic stenosis, cesarean delivery should be performed, and an individual approach is recommended for asymptomatic severe aortic stenosis. In non-severe aortic stenosis, vaginal delivery is favored according to these guidelines. Next, coming to coronary artery disease, it is not that these are, since our patients are in early reproductive years, we don't get coronary artery disease. Over last few years, we have seen quite a number of women who are under 37, 36, also having coronary artery disease history of having an MI in the past and have come with pregnancy. They desire that pregnancy and we require to optimize the outcome for these. These patients are at risk of serious events, and reported maternal mortality is between 0 to 23% in these cases. And 30% of pregnancies are complicated by adverse neonatal event also. The reason for adverse neonatal events in these patients may not necessarily be prematurity, but there may be patients who have been continuing drugs. If the patient has been for whatever reason and beta blockers, IUGR may be there in these patients. Now, post-acute myocardial infarction or acute coronary syndrome, what is recommended is if they are really very keen on pregnancy, then they delay pregnancy for at least 12 months so that the stabilization of this mother and her drug routine is done. And avoidance of further pregnancy is advised if she has come to us during pregnancy and we deliver her and send her away. So now the delivery also should be postponed if the during delivery MI occurs, during pregnancy MI occurs, at least 2 weeks we may try to delay the delivery if we are going to plan it electively. This is also to facilitate maternal management, and in the meanwhile patient has to be referred to an appropriate center with expert cardiologists available. So they can have assisted and monitored vaginal delivery, but depending upon their status of ejection fraction and likelihood of going into cardiac failure, etc., this would be changing. Coming to cardiomyopathies, we might have peripartum cardiomyopathy, hypertrophic cardiomyopathy, and dilated cardiomyopathies. So in peripartum cardiomyopathy, timing and mode of delivery should be individualized. We have to, of course, weigh maternal risks of continuing pregnancy against the preterm mortality. Depending upon the ejection fraction, again, vaginal delivery is a reasonable consideration for women with peripartum cardiomyopathy because it results in less complications for the mother. Mother becomes much more easier to manage and improve neonatal outcomes also. Also, we have to consider that these patients may be on anticoagulants for whatever, for the purpose of their cardiomyopathy. Then hypertrophic cardiomyopathy may have output problems, and then their mode of delivery will change depending upon how much is the output limitation. Dilated cardiomyopathy, actually pregnancy is contraindicated if patient has had dilated cardiomyopathy. They require prompt treatment of severe hypertension. Metabolic conditions like diabetes or hypertriglyceridemias require to be expeditiously treated in these patients. The risk of pulmonary edema and PIH is a very real risk, and that has to be also optimized. Actually, the risk of PIH is there in any of these patients, and that requires to be optimized. If there is pulmonary edema in any patient who we have seen immediately postpartum or during last month of pregnancy, for whatever cause, there has to be a high index of suspicion for peripartum cardiomyopathy, and an echocardiogram may help this diagnosis. Now, if suppose acute heart failure occurs during pregnancy, we have to get the baby's lungs mature and survivable for the turbulent preterm neonate. Then the gestational age at which that heart failure has occurred will decide how we deal with that. Parental wishes, though in our setups, normally patients with, they will come to us with folded hands and say, Doctor Sahab, aap jo karenge wo sahi hoga, jaisa aap bolenge waise karenge. But it is very important that we document every discussion that has taken place, and multidisciplinary consultation is done, and that all is documented so as to protect ourselves from an unnecessary litigation. Stabilization of patient and delivery in unstable patients is important in these cases. Dr. Sabnis also elaborated on this factor, that the patients who are on mechanical circulatory support, at that time we may require to do a cesarean section. Then delivery in stable patients, we have to plan, and along with diuretics, etc., they require to be delivered with cutting short the second stage. Anesthesia concerns become important because these patients will have again output problem. So the balance between an epidural, spinal may be contraindicated, there would be epidural, and there would be general anesthesia. But our anesthetists, we have seen that they are more comfortable with a controlled ventilation and general anesthesia rather than epidural. One, because the time it takes to instill the epidural catheter, and if the patient is, for whatever reason, has been on anticoagulants and she has come in failure, we require to balance the risks. Now coming to the congenital heart diseases, the case presented had referred to these modified WHO risk stratification. So the aortic dilatation cases where there is spontaneous circulation, cyanotic heart disease, and Marfan syndrome and aortic dilatation, etc., and bicuspid aortic aortopathy. So it depends upon the dilatation which is there, and the gradient would be, the grade would be different. Aortic dilatation less than 45 millimeters in bicuspid aortic valve aortopathy, and that beyond that in class 3, aortic dilatation of 40 to 45 in Marfan syndrome, above 45 in bicuspid aortic valve. So these are details that you and I may not be really able to have at hand to because patients may not have those reports so elaborately written. So it's between cardiologists and us, we will decide what we require to do with these patients. And of course, then the Eisenminger Syndrome. Eisenminger Syndrome, we have had successful vaginal deliveries of Eisenminger Syndrome, but it also depends upon what is the weight of the child, what is the gestation at which the mother is delivering, because whether we want to, if once she has gone to, and once the patient wants the pregnancy very desperately, every mother wants at least one child, and they come to us with pregnancy. They refuse termination of pregnancy. They go to go near term, whether to induce, whether not to induce, whether to allow them to go into labor spontaneously, whether to allow them to go to post-term pregnancies, the weight of the child, other factors which are associated with delivery. All these are the factors that require to be considered. So we require a multidisciplinary team. Screening fetal echocardiogram at 18 to 22 weeks, because the risk of congenital heart defect in the fetus is between 4 to 10%. Dr. Gadam had given the statistics of the cardiac risk to the baby also. Now, if there is a screening is positive, what all is to be seen in the screen is measurement of nuchal fold thickness at 12th week of pregnancy to screen for chromosomal abnormalities if you're doing these patients. And now we do this for almost every patient. Also screens for fetal congenital heart disease. For major congenital heart diseases, a 12-week ultrasound has a sensitivity and specificity of 85 to 99% respectively. And an incidence of congenital heart disease with normal nuchal fold thickness is much less. And those with high nuchal fold thickness, we require to do a full echocardiography, scanning for associated abnormalities of digits and bones. Then history of medical disorders, viral illnesses, and teratogenic medications is to be elicited. Fetal karyotype is required in conotruncal anomalies, and referral to fetal medicine specialist, pediatric cardiologist, and geneticist. Very few centers will have a geneticist at disposal, but this will do a lot of good to the baby and subsequent pregnancies of the mother, etc. Patients with transposition of great vessels. NYHA classes 3 and 4 with ventricular dysfunction and low ejection fraction or severe TR should be counseled against pregnancy. Fetal loss is more if there is cyanosis. Now, Fontan patients where there is, for any reason, there is a tricuspid atresia, or patient has got a direct circulation from right ventricle to the, or a single ventricle operated in the childhood and a shunting done, they have a high risk of miscarriage also. Then antenatal and peripartum bleeding is common in these patients, and increased risk of premature birth, fetal growth restriction, and neonatal death is there. Vascular Ehlers-Danlos syndrome, again the maternal mortality is significant and relates to uterine rupture because of the connective tissue problems. Resection of major arteries and veins also can occur in these patients, and pregnancy is therefore not advised. So these all become, these both become class 4 of modified WHO classification. What is genetic counseling is to, when is genetic counseling to be offered to these patients? In case of known carrier status of hereditary pulmonary arterial hypertension, in cardiomyopathies and channelopathies like long QT syndrome, congenital heart disease known to be associated with genetic abnormalities like conotruncal defects or bicuspid valve, patients with dysmorphic features, developmental delays, and other non-cardiac congenital anomalies such as Marfan or other heritable aortic diseases, and those with family history. So all these require genetic counseling. This is either preconceptional or antepartum. Now, what are the pregnancy implications for these patients? mandatory beta blockers that they may be on because of growth restriction in these patients. It is important to reduce cardiovascular stress of labor and delivery, and beta blockers should be continued even in the peripartum period. With aortic diameter of 40 to 45 millimeters, instrumental delivery with regional analgesia should be considered to prevent blood pressure fluctuations and peaking and risk of dissection of aorta. Now, cesarean section is recommended in aortic diameter of more than 45 millimeters and in patients with vascular Ehlers-Danlos syndrome, if she has come pregnant and she's keen on continuation of pregnancy, etc., or acute or chronic aortic dissection. General measures otherwise to be taken in cardiac disease. Assessment of fetal well-being, of course, because fetal growth restriction is common in maternal, congenital and acquired cardiac lesions. Then optimal time balancing the maternal and fetal risks. It is said that the chance of disability-free survival increases by approximately 2% per day between 24 to 28 weeks. So every day is very precious for these babies. Every day we prolong the pregnancy by. So here we have to balance the maternal situation and the fetal survival. And 1% per day thereafter until 32 weeks. And after 32 weeks, though in our centers, the outcomes may be grossly different between preterm and term babies, but in the West, the outcome between post 32 preterms and term babies is not significantly different. So delivery should be determined by umbilical artery and ductus venosus blood flow patterns, where we may have to take a call of delivering them even before 32 weeks. Birth planning. Women with stable cardiac disease can undergo a vaginal delivery at 39 weeks of gestation with cesarean delivery reserved for obstetric indications. So this means that we require to induce the labor. Now, why that we will see. About the analgesia, fluctuations in cardiac output or Valsalva efforts that patient goes through when she starts getting that bearing down sensation and rectal pressure, they occur during vaginal delivery. And for many patients, epidural analgesia during labor, it provides significant pain relief, minimizes catecholamine release and resultant cardiac output fluctuations and helps safe delivery. Now what we said is we will discuss why we should be inducing or whether we should be inducing labor. So it is recommended as per the guidelines that induction of labor at 40 weeks of gestation in all women with cardiac disease reduces the risk of emergency cesarean section by 12% and the risk of stillbirth by 50%. In women without cardiac disease also it reduces the risk of emergency cesarean section and risk of stillbirth. So it can be projected to the patients with cardiac disease, and the benefit is likely to be greater in women with cardiac disease who have higher rates of obstetric implications. Whether everybody agrees with this, I do not know, but at least when we require to decide on how long anticoagulation should be withheld, because somebody who is with warfarin and she has been well controlled on warfarin, her INR has been maintained well, and we have now unfractionated heparin or fractionated heparin, and their APTT is not being maintained well on unfractionated. These are the patients where we require to take a call on what sort of delivery we require to do and when we require to do that delivery. Now, intrapartum management of these patients. Intrapartum, very important is focus on maternal position. In the supine to lateral position cardiac output, the ratio of cardiac output is the change or the fall in the rise in cardiac output which occurs while turning from supine to lateral is if it is 15% in supine, then it is 10 to 11% in lateral position. So lateral position is recommended. Then effective analgesia and lateral tilt reduce this cardiac output fluctuations as well as blood pressure. When the patient's urge to bear down is there, lateral position also helps in reducing the fluctuations in the venous return, facilitating second stage by assisted delivery, either by forceps or vacuum, to avoid the Valsalva maneuver, and thereby it is important in those with critical obstructive lesions like aortic stenosis, bicuspid aortic valve aortopathy, coarctation, and PH. Some of these patients will have vaginal delivery, not all will have cesarean delivery. So that forceps becomes very critical. Then diuretics at placental delivery, we also discussed during the case presentation, and we continue to give diuretics at placental delivery. And lastly, the PPH control. What is the role of anesthesiologists in management of these cardiac patients is in delivery plan for cardiac monitoring, in giving labor analgesia, they have to be available when the patient starts going into active labor. Then cesarean anesthesia, postpartum monitoring of these patients, and cardiac emergencies. Severe anemia, Dr. Sabnis also alluded to. It may be associated with heart failure and myocardial ischemia, and hemoglobin should be checked each trimester in women with cardiovascular disease. Time of delivery we already talked. Now delivery mode. The pregnancy registries data has shown that elective cesarean section carries no maternal benefit and results in early delivery and lower birth weight. The blood loss is more, infection chance is more, venous thrombosis is more, and embolism is more. So elective cesarean is not the norm for all cardiac patients. When when vaginal deliveries are done, shortening of the second stage after descent for forceps application is important. And cesarean section is considered for obstetric indications and for patients presenting in labor on oral anticoagulants, because the neonatal risks of intracranial, fetal and neonatal risks of intracranial hemorrhage, and those with aggressive aortic pathology and in acute intractable heart failure. In these cases, cesarean section is recommended. It is also recommended in severe forms of PH, including Eisenminger Syndrome. Now, if suppose we require to do urgent delivery on therapeutic anticoagulation, like a patient has come with anticoagulant and we don't have time, she ruptures membranes or she has she's breech presentation and progressing rapidly, etc., what we should be doing. These patients have high risk of hemorrhage, and for unfractionated heparin, protamine sulfate should be given. The exact dose depending upon the time since the last dose. That 1 milligram will cover for about 100 units of unfractionated heparin. And in the case of low molecular weight heparin, regardless of whether we give protamine or not, there is that prolonged anti-factor 10A activity requires repeated doses. How to reverse this oral anticoagulation? 4-factor prothrombin complex, which is very, very costly actually. So one treatment would be upwards of $5,000. So it will be really not relevant to us. But FFP is given prior to cesarean delivery to achieve an INR which is less than or equal to 1.5. So one may require about 12 to 15 milliliters per kg body weight of FFP in these patients. Vitamin K, 5 to 10 milligrams IV, but it may take longer to start acting and longer to reverse also. And re-anticoagulation may be difficult with this. Then the fetus also may remain anticoagulated for 8 to 10 days after stopping maternal oral anticoagulants. And baby also, and fetus, neonate also requires fresh frozen plasma as well as vitamin K. This is the real tightrope walk when somebody is on therapeutic anticoagulation and she comes for urgent delivery. So for planned elective low molecular weight heparin is omitted 24 hours prior to surgery. Now in moderate to low risk, prophylactic dose of LMWH 20 milligrams if weight is less than 50, 40 milligrams if weight is less than 90 but more than 50 can be given 6 hours post delivery, and then regular LMWH can be given 12 hours later. Unfractionated heparin in high-risk mothers, when patient has taken unfractionated heparin and labor is going to be, it is not that labor, we start induction means she is going to deliver immediately. So we have a fair idea about how and when she is going to deliver. So infusion is to be started and it is to be stopped 6 hours before delivery. Vaginal delivery is planned with epidural, omission of, because anesthetists will not be comfortable giving epidural analgesia when patient is on anticoagulants. So unfractionated heparin 12 hours prior, it has to be stopped and APTT is to be monitored. Same applies to low molecular weight heparin also. What all is to be monitored in labor? Maternal blood pressure and heart in all patients, heart rate in all patients. In severe heart disease, arterial line provides more accurate data. Then pulse oximetry and continuous ECG monitoring for early signs of decompensation. Now we talked about epidural, but in obstructive valve lesions and low left ventricular output, epidural may not be really indicated. Rather, it is contraindicated. Coming to postpartum hemorrhage prophylaxis, infusion, what is recommended is a little more different than what we do. We do a 10 units IM, 20 units concentrated drip, etc. Recommended is 2 units of oxytocin given over 10 minutes in an infusion immediately after birth, followed by 12 milli international units per minute for 4 hours. So it requires that type of calculation, choosing appropriate diet or the drip and over your triplet monitor. It reduces the risk of PH. It has minimal impact on cardiovascular characteristics and Pci analogs and misoprostol. Misoprostol in the dose of 2,000 micrograms can be used to treat postpartum. I can hear another sound simultaneously. I'm sorry. Can it?
Padmaja, I can't hear. I can't see anybody. I'll mute all and then you unmute yourself.
Okay. I think they have stopped talking already.
Anyway, मैं वापस म्यूट कर देता हूँ सबको, तो अनम्यूट कर ले. Now you can unmute yourself.
Can you hear now?
Yeah,
yes,
clearly.
Clear. Carry on, Padmaja.
Yeah. So coming to lactation, lactation should be encouraged in patients with heart disease whenever possible. Anticoagulants, ACE inhibitors, renin inhibitors enter milk and could thus contraindicated breastfeeding. Same with our antiarrhythmic agents. In heart failure with reduced ejection fraction, breastfeeding is discouraged. Now, stopping lactation in these patients enables us to optimize the heart failure treatment. So now, if needed, lactation can be suppressed with either cabergoline or bromocriptine, either of the two. Briefly, I will touch upon this perimortem C-section. Now, a very controversial thing, but if suppose patient has collapsed for whatever cause, then resuscitation of patient is benefited. Not only the fetal purpose, but the maternal purpose also is served, and resuscitation may be better in patients who have no aortocaval compression. So these patients may require a perimortem C-section within 4 to 5 minutes of delivery, and their outcome is more optimized as compared to when baby has not been delivered. Termination of pregnancy, medical methods have made our life more easier, but call has to be taken with multiple factors, with how much drugs she has taken, what is the opinion of the cardiologist, etc. And this cannot be just to and fro passage of paper referrals. We require to really pick up the phone or personally talk to them and understand why, when they recommend termination of pregnancy, why they recommend, because we are always wary of cardiologists saying patient should be, pregnancy should be terminated. And we consider her whole obstetric career and we say, nay, if this pregnancy is there, let her carry because she is going to have the next pregnancy anyway, etc., etc. Now, these are the references which I had used. So I will stop here now. And if there are any questions.
No questions.
Okay, so thank you very much.
So elaborate, so detailed. Padmaja, who's going to have questions at all?
Yeah, thank you, sir. I have learned next from you, Dr. Gadam, Dr. Rajkumar Shah. So I better.
Anyway, pleasure, Padmaja. Thank you for joining us. Really a pleasure and finding time for us. RAN always needs you. So we'll be troubling you as the year goes on.
Thank you very much, sir. My pleasure.
Absolutely. Thank you, dear. Well, friends, in the last part of the session of the morning's program, I think hunger pangs may be showing signs in you, but please bear with us for a little long time. We have got the last short segment on cord prolapse. And I think we have got 2 or 3 students who are going to be discussing this. One is Dr. Divita, Dr. Manan, and Dr. Krupli. Am I right? Karthik, these 3 people have to be logged in.
Dr. Manan is there. Divita I can't find.
And Krupli was supposed to join us.
There's one Divi. I'll just make her a course if she is the one.
And of course, we have Dr. Geeta Balsarkar with us, who's been watching us for quite some time. Thank you, Geeta, for joining us on a Sunday morning. And you always been a friend of RAN. You never said no to RAN, always accepted our invite. So very thankful to you for that. And we'll continue if Manan is on. Manan, you're there?
Yes,
you said that we have done a lot of talking. I think Geeta and the rest can do that talking and ask questions. I think Sailesh also is not around. He's just on the screen. Sailesh also is at this time. I think Geeta, you can take on. Yeah, Manan.
Hello.
Yeah, Manan. Yes, Geeta, go for it. What do you want to discuss with her?
Yes. Come on.
No, we have to ask him questions, Karthik. Am I right? We are discussing the topic.
Because it can't be a case presentation, so we'll have to. Geeta, it'll have to be a question answer session, and then you can summarize it at the end.
Karthik, can we do the other way around?
Sure.
Because I have done a detailed presentation I have.
Okay.
We can go over it, and then if they have any questions, they can ask me, so it will be easier for us to discuss.
Sure. Or what you can do is during the presentation, you can ask them questions.
Ask questions. If they're not able to answer, then you show it.
Yeah, that we can do it. Okay.
Yes.
Now,
That'll be
before I
fine.
go to this, before I go to actual presentation of this cord prolapse, I would like to share a little bit with you. Since we are talking today about the cardiac diseases, I myself have a personal experience. Can you see my share slide?
Yeah, yeah.
Yes, clearly.
This is the actual aortic dissection I have faced of a patient, a 38-year-old preemie, 39 weeks of gestation, came to me with chest pain. Chest pain, most patients say here, isn't it? Can you see my photo? If you can see, they will say pain in the anterior portion of the chest. But this particular patient was telling me pain here, posterior portion of the chest. Okay. But she was very, very specific, a very sensitive, intelligent patient who told me that my pain is on the back side, but it is paining inside and I'm having chest pain. When I took the BP of this patient, it was like 130 by 40. You know, the gap was too large for me to be, sort of think of it as a gastritis or, something like that. So this patient came to me at Wadia Hospital. I immediately transferred this patient to KEM. She was in the medical ward for 2 days. They gave her IV fluids wherein the BP became normal. But somehow the dusky face of the patient, I didn't feel like sending the patient home. So I said, okay, I will induce you. So when this patient, during this process, she got, she was in early labor, 3 to 4 centimeters. She suddenly died. She suddenly died. My anesthetist told me, Geeta, this is something very big because her pupils immediately became fixed, dilated. I did a perimortem cesarean section. The baby today is alive and well. And this is her postmortem. This is a aortic dissection that she had. Okay, this is the aortic dissection. She had a cardiac tamponade. Cardiac tamponade along with aortic dissection she had. So this was her cardiac tamponade where the dissection is started right at the root of aorta. And so she immediately died and this proceeded down right till the where the renal arteries go out. The entire aorta has got dissected. I have also published this as a case in Bombay Hospital Journal in 2016. And so I just wish to say that it is not as uncommon as we think we are. So if anybody does complain of chest pain, but even little bit towards the back, it is worthwhile doing a 2D echo for the mother. Actually, it is much more available now than it was at 2016. So the point I want to make is wide pulse pressure and chest pain is not always gastritis. We have to look for cardiac cause in this patient, and maybe it is very rare, but I have come across, and this is the post-mortem of that particular patient. And this patient I have lost. It was a maternal mortality. I had to do immediate perimortem cesarean section. Baby is alive and well. Thank you.
Wonderful.
I just thought I would mention it. I was searching as Padmaja was talking. I searched for this. So now coming to my topic, this is umbilical cord prolapse. When I saw that I had almost an hour, I got really, worried that what am I going to talk for 1.5 hours on umbilical cord prolapse. So here it is. I have done a little bit of extensive study. So I hope that I will cover all the aspects of umbilical cord prolapse. So why are we even talking about this? Like, I should appreciate that in RAN Symposium, we have brought this topic of umbilical cord prolapse because of the burden of stillbirths in India, which is unacceptably high. We have a very, very high stillbirth, like 5.9 lakhs stillbirths in 2015 we had. Just like we are the global capital of diabetes, we have the largest number of stillbirths globally. India has the largest number of stillbirth globally. So what is the answer? With increasing attention on stillbirth worldwide, in 2014, as a part of the India Newborn Action Plan, it is called INAP, that is India Newborn Action Plan, the Indian government adopted a target of less than 10 stillbirths per 1,000 births by 2030, the first ever national stillbirth prevention target. And because of this, the Mumbai Municipal Corporation, the BMC, has already started collecting the data of stillbirth. Every stillbirth that happens in Mumbai, the obstetricians will soon have to give a verbal autopsy and submit a report as to why the stillbirth occurred. So there is need for improved data on the newborn death and stillbirth, and tracking of stillbirth is highly recommended in the INAP, and it is going to be followed by the BMC. It is already started in Vadia. Every month we are submitting our stillbirth data and what can be done, what could have been done to prevent the stillbirth. Now, as far as the cord prolapse, there are changing patterns and we are seeing improved outcomes over the past 15 to 20 years. Here, I have mainly referred to the Nyhc Intrapartum Care Guidelines of 2017 in addition to other references. So coming to definition, cord prolapse has been defined as a descent of the umbilical cord to the cervix alongside, which could be occult, or past the presenting part, which is the overt, in the presence of ruptured membranes. The cord presentation, there is a difference between cord prolapse and cord presentation. Cord presentation is the presence of the umbilical cord between the fetal presenting part and the cervix, with or without the membrane rupture. So there is a clear difference between the cord prolapse and the cord presentation. The incidence, the overall incidence of cord prolapse ranges from 0.1 to 0.6%. Because of the very low incidence, probably that is why it has not been highlighted so far. But the time has come when we need to really think of all the possibilities of stillbirth, and one of it is a cord prolapse. In the case of breech presentation, remember the incidence is higher and it is higher than 1%. Male fetuses appear to be predisposed to cord prolapse. I found this in 2-3 places, but somehow no other reason to corroborate with it. The incidence is influenced by the population characteristics and higher when there is a larger percentage of multiple gestations. With increasing ART techniques, and we are seeing more and more of multiple gestation, we as obstetricians have to be aware of this particular problem of cord prolapse. So if you see, it happens in 1 in every 100 births. So roughly in India, the incidence of umbilical cord prolapse is 1 in 100 births. So remember, in every 100 birth, you might be dealing with a cord prolapse or a cord presentation. Now, if we analyze the obstetric emergencies of all the obstetric emergencies, you can see that the cord prolapse is at the rather end, which I have circled in red. It is lower down, much lower down, and it is 1, and the percentage is 1.2%. So roughly 1 in 100 or 1.2% is what we see of the cord prolapse. And because the incidence is very low compared to the other obstetric emergencies that we normally see, we have not spoken much about cord prolapse. Now, perinatal mortality rate, however, is very, very high. It is 91 per 1,000 because of cord prolapse. Hence, we should be talking about this. Prematurity and congenital malformations also account for majority of the adverse outcomes associated with the cord prolapse in hospital settings. Birth asphyxia is also associated with cord prolapse. Asphyxia can result in hypoxic ischemic encephalopathy and cerebral palsy if the baby survives. The principal causes of asphyxia in this context are thought to be cord compression and umbilical artery vasospasm, which prevents the venous and the arterial blood flow to and from the fetus. So if at all the baby does survive, we have to rule out birth asphyxia because we don't want to have a baby with cerebral palsy. So what are the types of umbilical cord prolapse? You can have an overt prolapse or you can have an occult prolapse. Overt prolapse, when the cord exits the cervix before the fetal presenting part. If it is the cephalic presentation, it will be below the head. If it is breech presentation, it will be below the feet. Cord is palpable as a pulsating structure in the vaginal vault. Those of us who have done our residency in the 80s and 90s, we know how the placenta feels because we had to do PV examination those days for diagnosis of placenta previa and low-lying placenta. So similarly, once you have felt what a cord feels like in the vagina, you will never forget it. Unless you feel it, it is very difficult for you to imagine it. Diagnosis is clinical and made by palpation of a pulsating structure in the vaginal vault, or you could see it visibly protruding from the vaginal introitus. Occult prolapse occurs when the cord exits the cervix with the fetal presenting part. So the cord is not visible. It is not below the part, but it is alongside the palpable head of the fetal presenting part. The diagnosis should be a consideration in case of unexplained fetal heart rate changes. So we already saw that the cord presentation and cord prolapse, what is the difference? Remember, cord prolapse is life-threatening to the fetus and it is an obstetric emergency. So what factors are associated with a higher chance of cord prolapse? We have general factors and we have factors associated with various procedures. Coming to general factors, multiparity, low birth weight, preterm labor, wherein it could be even breech. Many preterms we know present as breech, fetal congenital anomalies, breech presentation, transverse or oblique or unstable lie. Sure enough, the cord will just slip out. Second of the twin, polyhydramnios, unengaged presenting part, and low-lying placenta, because the cord insertion is close to the cervix, so it can easily exit out. These are the general factors. Cord abnormalities such as true knot, low content of Wharton's jelly, or a single umbilical artery, they are associated with higher chance of cord prolapse. Now, what factors are associated with in the procedure related? So if you do artificial rupture of membranes with high presenting part, you could land up with a cord prolapse. Vaginal manipulation of the fetus with ruptured membranes. Sometimes you want to actually feel if there is, you are feeling the, what sort of position the fetus is. Is it left? Are you feeling the occiput or not? So you try to push the head a little bit up and you try to feel a larger portion of the skull. You could end up dislodging it and the cord could just escape from there. If there is an external cephalic version, during the procedure, you can have a cord prolapse. Internal podalic version, stabilizing induction of labor, insertion of intrauterine pressure catheter and large balloon catheter to induce labor. If you introduce more amount of fluid in the Foley's catheter that you have used to induce labor, you could just slightly, sort of push the head up and you could have a cord prolapse. These factors predispose to cord prolapse by preventing close application of the presenting part to the lower part of the uterus and or the pelvic brim. So now this if you see this particular chart, we can see that most common risk factor is a multiparity, and cord prolapse is seen more often during the around 37 weeks, or even in term patients, we see cord prolapse. Because in preterm, of course, we are going to deal with it, but somehow with term patients, we are relaxed and we don't anticipate cord prolapse. So these exactly are the patient who could have. So multiparity and gestational age more than 37 weeks, they are predisposed to cord prolapse. The other predisposing factors are, we already saw most of them: abnormal presentation, abnormal lie, preterm premature rupture of membranes, prematurity, artificial rupture of membranes, multiple gestation, uterine fibroid, distorting near the cervix especially, polyhydramnios. All these are the other predisposing factors. Now, if you see this particular diagram, you will see that as the parity increases, the frequency and percentage of cord prolapse increases. Most of the residents nowadays don't see more than second or the third gravida, rarely if ever a fourth gravida, but we have seen 7, 8, 9 gravidas were very common in the 80s and 90s. And as the parity increases, remember, the frequency and percentage of cord prolapse increases. So now this, sorry about this very crowded slide. What is the pathogenesis? How does it cause a cord prolapse? Each situation, like if it is prematurity or PPROM, it's a small fetal size. It doesn't fit snugly into the pelvis, and the cord can come from the side of the head. If the fetus is not shifted into the optimal delivery position, then even then the cord can come and slip out into the vagina. If it is PROM, membrane rupture before the contractions, and there is no contractions, lack of contraction helps to move the fetus in. The contractions actually help move the fetus into optimal position, and lack of contraction can actually slip, the cord can slip out. If there is low birth weight, smaller fetal size relative to maternal pelvis and amniotic fluid, so this will cause cord prolapse. Malpresentation, we all know, shoulder presentation, transverse lie, fetus is not in optimal position, therefore the cord can easily slip out. Polyhydramnios, if membranes are ruptured, there is a large volume of fluid that may push the umbilical cord through the cervix. Multiple gestation, because there is increased space for the fetus to move around once the first twin is delivered. And if the larger intrauterine space, there is risk of malpresentation. Till almost the first baby is delivered in twins, we are not sure whether the second one is going to be transverse, breech, or is it going to be cephalic. So that much amount of space is there inside the uterus, which can cause a cord prolapse. Multiparity, multiple fetuses, distend the uterus, increase in the laxity and increase in the space for the cord to come down. Actually, what happens is fetus does not adequately block the open cervix. Umbilical cord comes out through the cervix before the fetus does, and then causes this umbilical cord prolapse. It's an obstetric emergency, and it can cause cord compression and it can cause umbilical vasospasm. Both of these actually can lead to complicated variable fetal heart decelerations, prolonged bradycardia, neonatal hypoxic ischemic encephalopathy, cerebral palsy, and neonatal death. This particular pathogenesis and pathophysiology I have taken from a publication very, very recent, 17 February 2020. So a lot of studies are now going on about this cord prolapse. Remember, prevention is better than cure. So what are the strategies of cord prolapse? Awareness and anticipation of the risk factors. Antenatal ultrasound diagnosis in high-risk patients. Well, we'll come to that a little later. All times it may not be possible to antenatally diagnose it, but at least you can increase your suspicion. Vigilance during the procedures can increase, like amniotomy. You could have an assistant who's fixing the head so that the head actually comes down. Manual rotation of the head. And while during application of cervical ripening balloon and fetal scalp electrodes, we have to be very, very careful. So can cord presentation be detected antenatally? Routine ultrasound examination is not sensitive or specific for the identification of cord presentation antenatally and should not be performed to predict increased probability of cord prolapse. Cord prolapse was preceded by identification of cord presentation on real-time ultrasound along with color Doppler in only 12% of the cases. So we have about, almost 88% of the cases which is accident, and we really don't know why it has happened. So we cannot actually rely on ultrasound. But does that mean we don't do ultrasound? We definitely do ultrasound. So in this particular slide, if you see in a cord prolapse, 9% of the patients, they had suspected on ultrasonography because of the low-lying placenta or because of various reasons it was suspected, whereas 63% had detected only on PV examination. Whereas in a 4-line cord, 78% was detected on ultrasound scan, and they said that this patient could probably have a cord prolapse. So we have to remember that though ultrasound has no definitive role, it could probably increase your suspicion for whether you're going to have to deal with a cord prolapse. So reduce likelihood of cord prolapse at amniotomy. What can we do? What points can we inculcate from an individual point of view? Always assess engagement of the presenting part prior to induction of labor. See what is the presentation, it is cephalic or breech, if there is any cephalopelvic disproportion, and what is the baby weight. These are 3 things, very important thing before we induce labor in any patient. Look for umbilical cord presentation while doing PV examination to assess Bishop's score. It's not often that the residents have the cord presentation in mind when they do PV examination to assess whether the patient can be induced or not. But remember, if there's something pulsating on your fingers, you must think that if this patient can come with cord presentation or prolapse. Amniotomy should be avoided if the presenting part is high. Wait for the patient to progress in labor further before you can actually do the amniotomy. Remember, the new 6 is the old 4. In our times, we were told when the patient becomes 4 centimeters, you do an amniotomy and the patient will progress on our own. So nowadays, the new is 6. We have to wait for the patient to at least become 6 centimeters before we augment the labor with amniotomy. In that case, there is a slightly more descended fetal head and less chance of a cord prolapse. Now, this is a comparison. This chart gives a comparison between a spontaneous rupture of membranes and the amniotomy in relation to cord prolapse. We can see here that almost equal incidence of cord prolapse is seen in spontaneous rupture and those that we do the rupture, that is the amniotomy. So the bottom line is that whether the patient has a spontaneous rupture of membranes or whether we have done an amniotomy, we always have to be sensitive for a cord prolapse. In amniotomy, we will definitely come to know because our fingers are inside the vagina. But in spontaneous rupture of membranes, many a times we don't do PV examination. But remember, the incidence is same as that of amniotomy. So it is worthwhile doing a PV examination, even in those patients who have had a spontaneous rupture of membranes early on in labor. Please do PV to rule out a cord prolapse. Now, if you have compared this with gestational age and the baby weight, we see that just ignore the pre-viable, like less than 26 weeks which has got a very high incidence of cord prolapse because of a transverse or a breech presentation, we see a large amount in the gestation age 32 weeks onwards till term. And if you see the birth weight, majority of the cord prolapse patients have birth weight between 1.5 kg to 3.5 kg. The larger ones like this 4 kg onwards, there is less chance of cord prolapse because the head itself is huge and it doesn't allow the cord to come down. Whereas the lesser babies could be in another different form of presentation. Now, intrapartum, if you see, the maximum amount of cord prolapse occurs in multiparous patients near full dilatation. Remember, 10 centimeters dilatation is the maximum incidence of cord prolapse. You can see 4 centimeters where they actually do the ARM. Between 4 and 6 also the incidence is very high. But once you have crossed the 6 centimeters, then you have to be very careful at around 10 centimeters or full dilatation. And especially in multiparous patients, if the fetal part doesn't descend properly. Coming to the next one, here we have compared the intrapartum cord prolapse number of cases and the gestation age. You can see like around maximum cases of cord prolapse are between 36 weeks and 41 weeks, and the birth weight is between 1.5 to around 3.5 kg. These patients especially are prone for cord prolapse. Now, anytime during labor, remember, cord prolapse can occur anytime during labor, 3 centimeters, 6 centimeters, 9 centimeters, full dilatation. Therefore, you have to watch out for it. Acute bradycardia or single prolonged deceleration or more, think of cord prolapse. You have to have that at the back of your mind. Always think of cord prolapse if there is unexplained acute bradycardia or single prolonged deceleration. Can cord prolapse or its effects be avoided? Yes, it can be avoided, definitely. If we have the sixth sense, we can definitely avoid the cord prolapse. With transverse, oblique, unstable lie, you can have the patient electively admitted to the hospital at term or after 37 weeks of gestation, or at least explain to the patient that you have to reach the hospital as soon as you go into labor because you might have this particular accident called cord prolapse. Women with non-cephalic presentations and preterm labor rupture of membranes, they should be recommended in patient care. Artificial membrane rupture should be avoided whenever possible if the presenting part is mobile and or high. If it becomes necessary to rupture the membranes with a high presenting part, you call for an assistant who can fix the head, or you have to also have arrangements in place for an immediate cesarean section if it is required. Upward pressure on the presenting part should be kept to a minimum in women during vaginal examination. Many times residents, curious to see, they just tend to push the head a little big, a little up, and soon you will be having a cord coming down. And the other obstetric interventions, you have to keep in the context of ruptured membranes because the risk of upward displacement of the presenting part and cord prolapse. Rupture of membranes should be avoided. If vaginal examination, the cord, you already feel the cord. When you're going to do an ARM, you're already getting a feeling of pulsation. Please don't do ARM in these patients. When cord presentation is diagnosed in established labor, cesarean section is usually indicated. When should cord prolapse be suspected? Cord presentation or prolapse should be excluded at every vaginal examination in labor and after spontaneous rupture of membranes if the risk factors are present. In addition to fetal heart rate monitoring in labor, the fetal heart should be auscultated after every vaginal examination in labor. This we can easily do after every vaginal examination or after spontaneous rupture of membrane, auscultate the fetal heart, and also after spontaneous membrane rupture. Cord prolapse should be suspected. Then there is an abnormal fetal heart rate pattern, especially if such changes come soon after membrane rupture, either spontaneous or artificial. Speculum or digital vaginal examination should be performed when cord prolapse is suspected. When spontaneous rupture of membrane occurs, if there is a normal fetal heart rate monitoring and there are no risk factors for cord prolapse, then please don't do an unnecessary PV examination. Even that you can predispose by pushing the head a little up. So if after spontaneous rupture of membrane, it is prudent to auscultate the fetal heart. And if the patient has no risk factors for cord prolapse, I'm not asking you to a routine PV examination. What is the optimal initial management of cord prolapse in a fully equipped hospital settings? The patient is already in the hospital. When cord prolapse is diagnosed before full dilatation, assistance should be immediately called and preparation should be made for immediate birth in the theatre. There are insufficient data to tell you whether manual replacement of the prolapsed cord above the presenting part to allow continuous and this is not recommended. To prevent vasospasm, there should be minimal handling of the loops of cord lying outside the vagina. So what we see in teaching hospitals, especially whenever there is a cord prolapse, the registrar will do PV, then the houseman will do PV, then the junior most one will do PV. Everybody likes to feel the pulsations of the cord in the vagina. So remember, there should be minimal handling of the loops of the cord which are lying outside. To prevent cord compression, it is recommended that the presenting part be elevated either manually or by filling the urinary bladder. I know Dr. Shashank Parulekar has done extensive study on immediate filling of the urinary bladder, how it helps to, prevent the damage to a patient who has had a cord compression and cord collapse. Cord compression can be further reduced if the mother adopts the knee chest or left lateral, preferably with the head down and a pillow under the hip position. And the next slide, I will show you in a diagram what these positions are. And tocolysis can be considered while preparing for cesarean section. Tocolysis can be considered while preparing for cesarean section if there is persistent fetal heart rate abnormalities after attempts to prevent the compression mechanically, particularly when the birth you want to delay it and you want to just, she's 8 to 9 centimeters, so you want to sort of try and give her a vaginal delivery. Although the measures described above are useful during preparation of birth, they must not cause any unnecessary delay, or you could land up with the baby having ischemia. Ischemic hypoxic encephalopathy. What is the optimal mode of birth with a cord prolapse? Cesarean section is the recommended mode of delivery in cases of cord prolapse when vaginal birth is not imminent in order to prevent hypoxic acidosis. So there are two categories, category 1 and category 2. Category 1, cesarean section should be performed with the aim of achieving birth within 30 minutes or less. If cord prolapse is associated with a suspicious or pathological fetal heart rate pattern, but remember, the mother comes first. Do not compromise on the mother's safety. Category 2, cesarean birth can be considered for women in whom fetal heart rate pattern is normal, but even if the fetal heart rate is normal and you have a patient with cord prolapse, you must do continuous assessment of the fetal heart rate.
Geeta, 1 minute. Geeta, 1 minute. There's one Vidhi Gawande who's not muted. Vidhi, can you mute yourself, please? Vidhi.
Geeta, I'll mute all. And then you unmute yourself.
Okay, we already saw what was category 1, where we have to deliver these patients at least less than 30 minutes. In category 2, now this patient has come to you with cord prolapse, but the fetal heart rate is normal. Even if the fetal heart rate when you're seeing is normal, we have to do continuous assessment of the fetal heart rate. It's very, very essential. Discussion with the anesthetist should take place to decide the appropriate form of anesthesia. Are they going to give GA? Are they ready for GA? Does the patient have enough starvation? Or are they going to give regional? Regional, we may have to attempt in the lateral position. The patient cannot be made to sit up. Regional anesthesia can be considered in consultation with experienced anesthetist. Remember, if there is imminent severe fetal distress, verbal consent is also satisfactory for category 1, but vaginal birth in most operative cases can be attempted at full dilatation if it is anticipated that the patient can be delivered quickly and safely using standard techniques and avoid the impingement of the cord when possible. Breech extraction is appropriate under some circumstances like internal podalic version of the second twin. Sorry. Okay, remember, senior neonatologist competent with the resuscitation of the newborn should attend all births that follow cord prolapse, and paired cord blood samples should be taken for pH and base excess measurement, because we know we might be dealing with a hypoxia. So what are the positions that are associated with cord prolapse? The knee, chest, face, down position while waiting for hospital transfer. You can see these diagrams here and how the patient has to adopt the position. Suppose a cord prolapse has occurred at home or in a primary healthcare center, and now you're shifting her to a tertiary healthcare center. This knee chest face down position has to be adopted while hospital transfer. During emergency ambulance transfer, however, if the patient takes the knee chest face down position, she may fall down because the ambulance will go fast, or it can suddenly break. So then in that position, you have to do the exaggerated Sims position. Left lateral with a pillow under the hip should be used. And remember, bladder distension does really help in a patient of cord prolapse. So here they have compared the various measures like bladder filling with saline, maternal oxygenation by face mask, Trendelenburg position. No additional measures were given. Manual replacement of the cord packing with moist saline gauze, tocolysis. They found that if you say the most commonly used are the bladder filling with saline, then comes people give oxygen, then the Trendelenburg position, and some of them, don't even use any measures. Now, this is the result of a rapidly filling urinary bladder in a patient of cord prolapse. You can see here how the fetal heart rate has gone down like a trough very significantly. And the moment the bladder was filled rapidly and clamped, you can see how it has started rising. And this gives us little time. As the assistant in doing this, it gives us time to mobilize the cesarean section. What is the optimal management of cord prolapse at the threshold of viability? We are not sure, 24, 25, 26 weeks. We are not sure whether it will survive, not survive. So there is no evidence to support replacement of the cord back into the uterus when prolapse occurs at or before the threshold of viability. Women should be counseled. You can say that you can continue and terminate as well following cord prolapse on the threshold of viability, and it has to be highly individualized. The woman has to be counseled, her consent has to be taken into account. So now if you see this particular is the baby viable? Yes. If the baby is viable, is the cervix fully dilated? Yes. Then we can consider venous delivery. If the cervix is not fully dilated, put Foley's catheter immediately. Fill bladder with 500 ml normal saline. Continuous fetal monitoring with CTG and transfer into the theater for cesarean section. At skin incision, we have to release the clamp on the catheter. Otherwise, you might just end up, sort of incising the bladder. Remember, and before you're taking the skin incision, release the clamp on the catheter and allow the bladder to drain. If the fetus is not viable, confirm IUD on delivery and ultrasound. And then even with cord prolapse, you might wait spontaneous delivery. So this is the, management protocols. Call for help. First and foremost, like any other obstetric emergency, call for help. Continuous fetal monitoring, oxygen by face mask, immediate delivery, essentially by cesarean section, and allow instrumental vaginal delivery if you think that could be quicker. Inform the anesthetist, pediatrician, take patient consent. Tunic decompression or elevation of the fetal present or the presenting part. We know as residents, we have kept the fingers in the vagina. We are not allowed to take it. If you find that, you have diagnosed a cord prolapse, 2 fingers remain in the vagina. And the steep Trendelenburg or knee chest position, insertion of Foley's catheter and filling the bladder, and tocolysis, not a first line management, can be considered if you're going to take some time. And the idea is to keep the cord moist. With the cord extruding in the vagina, the cord tends to dry up and go into further spasm. So we try to keep the cord moist. Now you see from the 1940s to the 2000, how the proportion of cesarean sections has gone up for cord prolapse. At the same time, the perinatal death because of cord prolapse has come down significantly. So cesarean section does indeed help in immediate delivery in a patient who is not going to deliver very soon with cord prolapse. Now, this is a comparison of cesarean delivery, which of course we all know has gone up significantly, a forceps delivery, a spontaneous vaginal delivery, a venous delivery, and a breech delivery in a patient with a cord prolapse. How we have progressed from 1940s to the 2000s. Now, what are the predictors of perinatal outcome? Location of the cord prolapse. Is the patient inside the hospital? Is the patient outside the hospital? What is the diagnosis to delivery interval? Very, very important. Less than 30 minutes, you might have a favorable outcome. More than 30 minutes, less favorable outcome. What is the birth weight? Bigger babies tolerated better. So if it is more than 2.5 kg, it will be better outcome. Less than 2.5 kg, less favorable outcome. Mode of delivery, cesarean delivery has a favorable outcome, and less favorable outcome could be post vaginal or any other operative delivery. decision delivery interval is very, very important. From where you have diagnosed the cord prolapse, you have decided to deliver this patient, and what is the actual timing of delivery. That is very, very important. We can see here from less than 30 minutes to more than 180, how the percentages of survival goes down. So we have to remember that your diagnosis, decision to delivery, and the delivery actual time is very, very important in a case of cord prolapse. Cord prolapse demands general anesthesia. This was done in an anesthetist meeting where they had voted and they had tried to see that how many are for general anesthesia and how many were against general anesthesia. Most anesthetists preferred general anesthesia for cord prolapse. Very few were actually ready to give immediate spinal in the left lateral position. Cord clamping, delayed cord clamping can be considered if the baby is uncompromised at birth. Immediate resuscitation should take priority of the delayed cord clamping when the baby is unwell at birth. A Cochrane review concluded that in term infants, delayed cord clamping should be assessed at each birth, especially in infants where access to good nutrition is poor, and this simple intervention may be advantageous. So if you have a preterm birth, if you have an IUGR, and you feel that this baby's nutrition is affected and they come to you with cord prolapse, you can still consider delayed cord clamping, where you can give the baby a little extra blood, provided the baby is uncompromised at birth. Now, I came up with this very, actually to say very, surprising study. I have not heard of this before. Metformin and umbilical cord prolapse. A phase 4 clinical study is going on. Actually, from 2012, we can see how they are analyzing those patients with umbilical cord prolapse who are taking metformin. Actually, it could be more to do with mother's glycemic control, or it could be more to do in mothers who are actually obese and who have been started on metformin for preventing further weight gain. But I don't have much more details about this. It is an ongoing study. So when it comes, I'll present it further. So what is the best way forward? We have to have simulation training, at least for the resident doctors. Recognize those women who are at highest risk of umbilical cord prolapse. Quick assembling of healthcare personnel involved in the management. Like any other obstetric emergency, we should have quick assembling of the healthcare. Practice the maneuvers to elevate cord compression. Improve diagnosis to delivery interval to less than 50 minutes.
Geeta, I'll mute all. You unmute yourself.
Why people are muting here? Are you muting?
Yeah, unmute yourself.
Yeah. To improve the diagnosis to delivery interval to less than 30 minutes. Ensure effective, comprehensive patient and family understanding as to what has happened. And least but not the last, improve your documentation. Very, very important. What was the time the cord prolapse was diagnosed or suspected? What is the baby delivery time interval? How much is the time? Do entire documentation. So this is very, very important even in case of cord prolapse. So thank you for a very patient hearing, and I can take any questions if you have.
Geeta, this is perhaps the most comprehensive lecture I've heard on cord, right from my undergraduate days. Let's be honest about it. I don't know the amount of data. This is perhaps your interest in stillbirths, which has made you go into the depth of this topic. If you look at any book, there's not more than half a page or a page on this topic. That's how it is. But fantastic documentation. Your studies and all, this is a beautiful job. I just one comment to make regarding, as you said, in our resident days, I remember the junior most RR house surgeon used to come with his fingers in the vagina, patient on a trolley going to the theater. But what I understood over a period of time is that particular finger, once you have dislodged the particular head on top, pushed it up, get it up and go on the abdomen and hold the presenting part of the abdomen till you can fill up the bladder. Because that hand contacting the cord is going to make it all the more, going to vasospasm and mess up your chances. So hold it up, fill up the bladder.
Keeping the hand inside is to prevent it from coming out of the vagina.
But then once you have the cord, play with the cord the least you can, play with the presenting part the most you can. Anyway, thank you so very much, Geeta. Any questions? I don't think there can be any questions because you've been so very elaborate.
No question. Excellent, Geeta.
Absolutely fantastic. You are into the groove. We loved every bit of it. Thank you so very much.
Thank you.
Though we had to change the format, I think this was very, very good.
Yeah. Perfectly done. And a long talk. Really good talk. Yes, Karthik, you can hand it over to you on whosoever have been with us, the faculties, in case they're around. Thank you so very much on behalf of VFG for finding time. Karthik, you can do the final statements, please.
No, I mean, thank you for being with us. Now, RAN Symposia will be usually on the first Sunday, usually on the first Sunday of the month. We'll decide the date and tell you. This time, because of ICOG, we had to ISCOG, we had to AICOG, we had to change the timings. But we will let you know. So the next RAN symposia will be probably the 1st or the 8th of next month. Thank you so much for being with us. All right. Bye-bye.
Have a great lunch. Thank you. Bye-bye.